call this meeting to order. Welcome. Agenda item number 1 is approval of the minutes. Included in your packets are copies of the minutes from the February 16th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion to approve. Motion. Second. Second. Any discussion? All in favor? Any opposed? Minutes are approved. Commissioners, you've received the written updates from our centers. Do you have any questions on the written updates? If not, Ben, do you or any center directors have any additional updates?
So I will be providing a second written update to the commissioners outlining and describing some of the activities over the last week, but given the agenda today, I will pass on any further comment.
Perfect. Because I served as the reviewer of the applications in the Baltimore Upper Shore Cardiac Surgery Review, Commissioner Stollenwerk will chair the meeting for the next agenda item.
I'm having trouble hearing you. This is Dr. O'Connor.
Okay. Let's see. We'll work through the acoustics, Jerry. And,
okay, that's better. That's better.
Okay. All right. Thanks. Give us a minute.
Good afternoon, everyone, and thank you, Commissioner. First, I want to note that 3 commissioners, Commissioner Phillips, Commissioner Carr-York, and Commissioner Pollock, have recused themselves from participation in this matter. As Commissioner Tanio noted, he served as the reviewer in the Baltimore Upper Shore Cardiac Surgery Review. Each applicant, Anne Arundel Medical Center and the University of Maryland Baltimore Washington Medical Center, or BWMC, filed an application seeking Certificate of Need approval to establish cardiac surgery services. Each applicant was recognized by Commissioner Tanio as an interested party in the other's application. In addition, Commissioner Tanio recognized other interested parties: Dimensions Health Corporation, which does business as Prince George's Hospital Center; LifeBridge Health Incorporated, which does business as Sinai Hospital; 2 MedStar Health Hospitals, MedStar Union Memorial Hospital and MedStar Washington Hospital Center; and the Anne Arundel County Health Department. Anne Arundel County was recognized as a participating entity in the review. On December 30th, Commissioner Tanio issued his initial recommendation. This isn't in the review. And after filing of exceptions and AAMC's, or Anne Arundel Medical Center's, AAMC's response to exceptions, Dimensions filed a motion to strike the December 2016 recommended decision. Are we doing okay with the phone? I hear some feedback.
Maybe, Jerry.
Is it? Okay. All right, so Commissioner, we will open up the mute when it's time for discussion. Okay. Commissioner Tanio denied, let me back up. After filing of exceptions and AAMC's response to exceptions, Dimensions filed a motion to strike the December 2016 recommended decision. Commissioner Tanio denied the motion. However, he stated that the parties should have had additional time, or should have additional time, to comment on data from the Virginia Health Information Discharge Data Set, as well as the record layout for the previously provided 2020 Nielsen population projections that were inadvertently omitted from the record, as well as other data that had been previously admitted to the record. So on March 3rd, 2017, Commissioner Tanio issued a revised recommended decision in the Baltimore Upper Shore Cardiac Surgery Review. I note that Assistant Attorney General Deborah Donahue will be assisting me during this exceptions hearing. So before we go to Commissioner Tanio, I want to recognize Commissioner Sargent, who has a statement to make.
Thank you. So it was brought to my attention yesterday that in 2014 and 15, the CEO of CareFirst sent in 2 letters commenting on the AAMC application. I was not party to any discussion relating to those letters inside of CareFirst, and CareFirst is not a party to this proceeding. I reviewed yesterday that issue with the Executive Director of the State Ethics Commission, and I reviewed it with CareFirst's Internal Compliance Officer, and it does not meet any of the reasons for recusal under the Ethics Code, and I think I have a duty to proceed to decide the case where recusal is not warranted. So I am not going to recuse myself, but I wanted to make sure everybody was aware.
Thank you. So Commissioner Tanio, please introduce your revised recommended decision.
Thank you, Commissioner Stolenwork and the Commission. You have received my revised recommended decision, which outlines the reasons I recommend that the Commission award a CON to Anne Arundel Medical Center, or AAMC, to establish cardiac surgery services, and that the Commission deny the application of the University of Maryland, Baltimore-Washington Medical Center, or BWMC. I have some brief remarks to set the appropriate context before you begin the exceptions hearing. So structurally, we have a situation that has 2 competing applications and multiple interested parties. As a result, we have a situation in which almost any solution would have multiple opposed parties. On the approach in conducting this thorough review, I analyzed the excellent proposals put forth by both AAMC and BWMC and considered the positions of the interested parties and the participating entities and reviewed all of the relevant facts in detail. I systematically looked at the entire set of options, approving no CON, approving both CONs, or approving one CON. On the environment, it's important to note in the context that this is the first CON considered under the relatively new Cardiac Surgery and PCI Services chapter of the State Health Plan. It's also influenced by the changes in the new all-payer model that created a global hospital budget for the state, which I considered carefully based on further written communications provided by the HSCRC. In this global budget environment, both parties offered an approach that offered the potential to lower overall costs as a result of moving cases from higher charge settings to lower charge settings. As healthcare technologies evolve, it's important that we find ways to encourage lower cost technology adoption. To help assure that these realized promised savings were met, I requested and received financial commitments from each applicant and its collaborating partner that neither would approach the HSCRC to seek an increase in rates based on shifts in cardiac surgery volume. The financial commitments received in this review, I believe, create an important precedent. I recognize the enormous amount of work that has been put into this review by the applicants and the interested parties, and I found reasons to support each of these proposals. However, on balance, after analysis of the huge written record in this review, I found more reasons to support the proposal put forth by AAMC, which, unlike BWMC, met each applicable standard and criteria. I believe that if my revised recommended decision is adopted by the Commission, that the high-quality cardiac surgery program that AAMC will establish will benefit patients and their families who live in Anne Arundel County and the region's Eastern Shore counties. Based on the evidence in the record of this review, I've also concluded that the approval of AAMC's application will not have an undue negative impact on any hospital that currently provides cardiac surgery to Maryland residents. And that concludes my initial remarks. I'll have additional remarks following the exception hearing. Thank you.
Thank you, Commissioner Tenio. So, written exceptions to the revised recommended decision were filed by applicant BWMC and by interested parties Dimensions and the MedStar hospitals. The other interested parties, Anne Arundel County Health Department and LifeBridge Health, did not file exceptions. The only participating entity in the review, Anne Arundel County, did not file comments or request an opportunity to address the Commission today. Each of you has received copies of the revised recommended decision, the exceptions, and the responses to the exceptions. The Commission will conduct an exceptions hearing prior to acting on the reviewer's revised recommended decision. Interested party, Baltimore Washington Medical Center, or BWMC, will have 15 minutes to present oral argument on its written exception. Interested party Dimensions will have 10 minutes to present its argument, and the MedStar hospitals, which filed joint comments and exceptions, will also have 10 minutes to make its oral argument. Applicant Anne Arundel Medical Center will have 15 minutes to present its argument. The Commission will hear oral arguments in the following manner. First, Baltimore Washington Medical Center, through counsel Tom Dame, will go first. BWMC has 15 minutes and can reserve part of its time for rebuttal. Dimensions Health Corporation, through counsel Natalie McSherry, will argue next. Dimensions has 10 minutes and can reserve part of its time for rebuttal. The MedStar hospitals, MedStar Union Memorial and MedStar Washington Hospital Center, through its counsel John Brennan, has 10 minutes and can reserve part of its time for rebuttal. Then, Anne Arundel Medical Center, through counsel Barry Rosen, will have 15 minutes for oral argument. Following any rebuttal arguments, we will hear from Commissioner Tenio. The Commission will then take action on the revised recommended decision. In accordance with the ruling, with Commissioner Tanio's ruling this morning, granting Dimensions motion to strike and motion in limine, AAMC is precluded from arguing that the impact standard does not apply to Dimensions in this review. Now, during today's proceedings, Council may introduce party representatives who are present and state their position titles, but please no biographies. Those introductions and titles will not be counted against the permitted time for argument. And then Assistant Attorney General Donahoe will keep track of time. So with that, I call up Mr. Dame.
Thank you, Commissioner Solomon. I would like to begin by introducing some of the people who are here today from the University of Maryland Medical System and from the University of Maryland Baltimore Washington Medical Center. First, and I'd ask each of them to stand to wait. You can see who they are. First is Karen Olskamp, President and Chief Executive Officer, University of Maryland Baltimore Washington Medical Center. Next is Robert Krensick, President and Chief Executive Officer, University of Maryland Medical System. Next is Dr. E. Albert Reese, Vice President for Medical Affairs, University of Maryland, and Dean, University of Maryland School of Medicine. Next is Corpet Sonal, Vice Chairman, Board of Directors, University of Maryland, Baltimore Washington Medical Center. Jeff Parminger, Secretary, Board of Directors, University of Maryland, Baltimore Washington Medical Center. Louis Zagarino, Member, Board of Directors, University of Maryland, Baltimore Washington Medical Center. Kathy McCollum, Senior Vice President for Clinical Integration and Chief Operating Officer, University of Maryland, Baltimore Washington Medical Center. Al Peach, Senior Vice President. Thank you. Al Peach, that's better. Senior Vice President and Chief Financial Officer, University of Maryland, Baltimore Washington Medical Center. Allison Brown, Senior Vice President and Chief Strategy Officer, University of Maryland Medical System. Becky Posh, Vice President for Strategy and Business Development, University of Maryland, Baltimore Washington Medical Center. Patty Willis, Senior Vice President, Strategy and Communications, University of Maryland Shore Regional Health. Karen Lancaster, Vice President, Media Relations and Corporate Communications, University of Maryland Medical System. Lori Fetterman, Strategic Planning Project Manager, University of Maryland Medical System. Andy Solberg, Consultant. Aaron Foreman, Manager, Advisory Healthcare Solutions, KPMG. And my colleague, Ella Aiken. And I will say that if we persuade you today, Ms. Aiken deserves much of the credit. Doesn't go well, it's my fault.
Mr. Day, before you begin, if you could let us know whether you plan to reserve time for rebuttal.
I do, Commissioner Stallwork. I would like to reserve a minute, 30 seconds, or whatever may be left again.
Whatever's left. All right.
Thereabouts.
Okay, thank you.
And we're passing out some handouts, which, if I may, just wait till they get around the room before I begin. And I will refer in my presentation to the page of the slides that accompany what I'm going to be talking about. I'll also say I'm glad that you did not count the introductions against my time. Do all the commissioners have the handout? I think we're ready when you are, Commissioner Stallman.
Please proceed.
Okay, thank you. Commissioners, the revised recommended decision should be rejected. Baltimore Washington Medical Center proposes adding a new location to the University of Maryland Division of Cardiac Surgery, which has a significant market share for cardiac surgery services both on the Eastern Shore and in Anne Arundel County. BWMC will serve as a lower cost, more convenient alternative for clinically appropriate cases that today and otherwise would be performed at the University of Maryland Medical Center. BWMC will move about 150 such cases each year, plus some more from competitive market share. By contrast, Anne Arundel's proposed program would seek case volume mostly through competition with existing programs. This is a comparative review. Each applicant must demonstrate that it meets all of the review criteria and standards. If they both do, then a comparative review standard is applied. Here, the comparative review standard was not applied. Instead, the revised recommended decision recommends denial of BWMC and approval of Anne Arundel based upon the determination that BWMC did not meet all of the standards in review criteria. You should reject the proposed decision for a number of important reasons, all of which are discussed in our written exceptions, and I will address 3 of those reasons in my limited time here. First, you should reject the reviewer's conclusion that BWMC does not meet the minimum volume standard because the reviewer misapplied the standard and added a new requirement to the standard. The reviewer's finding on minimum volume also is the sole basis for finding that BWMC did not meet the need standard and the cost effectiveness standard. An applicant must demonstrate the ability to achieve at least 200 cardiac surgery cases in its second full year of operation. In more than 30 years of cardiac CON reviews, applicants have consistently demonstrated this by documenting internal physician referrals and cardiac cath lab volume. BWMC did this, documenting 259 physician referrals plus internal cath lab volume. This alone met the standard, but BWMC also documented an even stronger source of volume, a significant volume shift from University of Maryland Medical Center with the full support and cooperation of UMS. But rather than scrutinize this documentation, the reviewer developed an alternative forecast model, a brand new methodology revealed for the first time in the recommended decision. It doesn't appear anywhere in the state health plan or in any other regulation. As explained in our written exceptions, where an agency changes a policy of general application and then seeks to apply it retroactively, that must be done by rulemaking. It cannot be done through a contested case adjudication. looking at slide 3 now. Also, the alternative model is logically unsound. It is based on 3 overly simplistic steps as shown on slide 3. First, the model identifies the zip codes from which 85% of a hospital's med-surg volume is derived and projects cardiac surgery cases in those zip codes. Second, the model assumes a hospital will have an 18 to 20% market share of those cardiac surgery cases. And third, the model assumes the resulting cases in the hospital's med-surg service area will comprise 66% of the volume, and another 34% will come from outside of the service area. Now, slide 4. Boiled down, this simplistic new methodology concludes that if the applicant's med-surg service area will contain at least 660 cardiac surgery discharges, that's the magic number, then the applicant meets the new minimum volume standard. If not, it fails. Thus, the model imposes a new test for a generic suburban hospital, as though they were all the same. Anne Arundel praises the model, saying that it compares apples to apples, but the standard doesn't call for comparing applicants. And in fact, comparing the applicants here is inappropriate because the 2 proposals are based upon entirely different sources of volume. Anne Arundel proposes to achieve volume through competing with other programs, and BWMC will primarily ship cases within the system today, a volume source that was completely ignored by the model. Had this new model been subjected to the rulemaking process, as it should have been, you would not have adopted it because of all of the flaws that we've described in the written exceptions. I'll describe a few of these. We're now on slides 5 and 6. First, the model illogically rewards applicants for low market share in any zip code within its med-surg service area and penalizes an applicant with high market share. Anne Arundel has a weaker average market share in its med-surg service area than does BWMC. But by definition, Anne Arundel's med-surg service area is larger than BWMC's because it requires more zip codes to achieve 85% of its med-surg volume. In fact, if we remove the zip codes in which the applicants have low med-surg market share, say 20% or less, the hospitals actually have similarly sized service areas, shown on slide 7. Second, the model compounds this error by applying a flat 20% market share assumption to each zip code, regardless of the applicant's actual market share in the zip code. BWMC has a high market share, an average of 42% across its med-surg service area. For Anne Arundel, more than half of the people in its med-surg service area live in zip codes where Anne Arundel has a market share that is below 20%. Yet the model gives both hospitals equal credit in all of the med-surg service area zip codes. Now, to derive this flat market share, the reviewer used data from 3 supposed comparison hospitals. But these hospitals are not similar to BWMC in the data measured by the model, and none of them principally derives its volumes from shifts within a hospital system, as does BWMC. Each has a med-surg market share in its service area of no more than 10%. BWMC's 42% market share is more than 4 times greater. Also, the comparison hospitals have a cardiac surgery market share that's higher than their med-surg market share in the same market, in the same service area. Yet the model gives BWMC a cardiac surgery market share that's 50% lower than its med-surg market share in its service area. Third, the model does not account for any existing cardiac surgery volume that will shift from within an applicant's existing hospital system. Thus, it ignores UMS's substantial market strength, the very premise of BWMC's proposal. The University of Maryland Cardiac Surgery Program has significant cardiac surgery power within the proposed BWMC cardiac surgery service area, as shown on the map on slide 10, shown over here as well. UMS hospitals had 320 cases in this area in 2014. The model's conclusion that BWMC could achieve only 130 cases defies logic. The second map on slide 11, also shown across the room, shows the relatively weaker position of Johns Hopkins, Anne Arundel's partner, in Anne Arundel's proposed cardiac surgery service area. Johns Hopkins had just 144 cases in this area. UMS is much better positioned to shift volume to its wholly owned affiliate. By failing to consider the significant strength of UMS and the weak market share of Johns Hopkins, the model underestimates BWMC's volume and overestimates Anne Arundel's. This fallacy shows up quite clearly when we look at the two most populous zip codes in both hospitals' med-surg service areas, as shown on slides 12 and 13. BWMC's med-surg market share in both of these zip codes is 63%. Anne Arundel's is only 7% in one and less than 4% in the other. Yet the model credits each hospital with a 20% market share. This flaw is further highlighted by the current relative market power for cardiac surgery of UMS and Johns Hopkins in each of these zip codes. In 2014, UMS performed a total of 79 cases in these zip codes, and Johns Hopkins, Anne Arundel's partner, performed only 13. Yet the model illogically assumes that either applicant would achieve 25 cases. The Commission should reject the alternative model, not only because it constitutes improper rulemaking, but because it's wrong. It doesn't measure what it purports to measure, especially as applied to BWMC, which will shift volume within the UMS system. To accept the alternative model, you must conclude that UMS, the largest provider of cardiac surgery services in the state of Maryland, which performed over 1,400 cases in 2014, will not be able to shift just a fraction of those cases to a more convenient, lower-cost location. The next major flaw in the recommended decision is that it fails to accurately assess the adverse impact that Anne Arundel's proposal will have on Prince George's Hospital Center. Because BWMC will draw most of its volume from within the UMS system, its impact analysis shows no significant adverse impact on any other program. The impact from Anne Arundel's program is very different. Virtually all of its volume is coming from competing against unaffiliated existing programs. And its proposed cardiac surgery service area includes zip codes from which today Prince George's derives 40% of its case volume. Now I'm looking at slide 14. Neither Anne Arundel nor the reviewer conducted a proper impact analysis. While the reviewer recognized some impact on Prince George's, he failed to determine the extent of it and to assess whether Anne Arundel meets the standard. Instead, he merely identified several thousand cardiac surgery discharges in most of the highly populated counties in the state. And he declared that there are more than enough cases for Anne Arundel and Prince George's to share. This belief directly conflicts with the reviewer's rigid view of BWMC's ability to achieve 200 cases. There is simply no way to reconcile the alternative model with the reviewer's faith that Anne Arundel and Prince George's can coexist. Now, adverse impact on Prince George's is a very important issue, but I know that Dimensions will address it extensively, so I will not say more on that topic now. The third major flaw is that the reviewer improperly rewrote the financial feasibility standards to find Anne Arundel compliant. We're looking at slide 17 now. The feasibility standard requires that a cardiac surgery program shall be financially feasible and shall not jeopardize the financial viability of the hospital. In particular, an applicant is required to document that within 3 years, it will generate excess revenues over total expenses for cardiac surgery. In finding Anne Arundel compliant, the reviewer proposes to rewrite this standard to remove the express specific requirement that the new cardiac surgery business line, standing alone, must be financially feasible. Instead, the reviewer found that it was enough for Anne Arundel to show only that the viability of the overall hospital would not be jeopardized. The Commission is not permitted to rewrite regulations in the course of a contested review. It must apply the plain meaning of the regulation, even if you wish now to change it. Here, the reviewer commented that the Commission would not have adopted this regulation in this form if it had only known how the HSCRC would address revenue for market shifts. As secondary support, the reviewer appeared to give some weight to Anne Arundel's argument that it can establish feasibility through what it called a conventional accounting perspective, because its billed charges will exceed its expenses. This is a pretense, because it is undisputed that Anne Arundel will not retain all of the billed revenue. The hospital's GBR will be reduced in an amount equal to 50% of the cardiac surgery billable charges as a result of the way the HSCRC addresses revenue from market shifts. Thus, the true economic impact of the cardiac surgery program will be that it will receive only 50% of the billable charges. In fact, Anne Arundel has admitted this by projecting feasibility in this way throughout the review until it learned that it could retain only 50% of the revenue, not the 85% it expected. Also, Anne Arundel continues to use this approach in arguing that its proposed program is cost-effective. Its arguments today conflict with those other positions. Commissioners, for these reasons and for all the reasons detailed in our written exceptions, BWMC respectfully requests that the Commission reject the revised recommended decision. Thank you very much.
Thank you, Mr. Dame. So you did reserve your minute and 30 seconds, so we're
Thank you. I made it.
You did. Well done. Well done. Mrs. McSherry? Yes, Mrs. McSherry.
Thank you very much. Good morning. My name is Natalie McSherry. I'm an attorney with Cramont and Graham representing Dimensions Health, Health System, Prince George's Hospital Center. With me today is my colleague, Christopher Jeffries, who, like Ms. Aiken, gets all the credit if everything goes well today. But we do have a few handouts and some poster boards, if I may, because I'm a bit of a dinosaur when it comes to technology, so I go with the poster board. Do you have a handout? Yeah. I didn't bring as many handouts as BWMC did. I didn't bring as many people as BWMC did either, so we're probably going to stay even on that score. Mr. Jeffries will pass those out. Mostly I have copies for the commissioners and for council, and we'll take it from there. I do want to also make a few introductions while those are being handed out of people who have come today with me on behalf of Dimensions Health System. And if they could stand, we have Neil Moore, who is the president and CEO of Dimensions Health System. Carl Jean-Baptiste, who is the senior vice president and general counsel. Jeff Johnson, senior vice president, strategic planning and business development. Terry Haber, who is a cardiovascular consultant. And Craig Wheelis, who is a director at KPMG and has served as a consultant on this matter. Excuse me. I too would, yes, go ahead. I would like to reserve 1 minute, please. I was going to say 2, but I watched Mr. Dame struggle. So, and I have less time than he does. So I will try to do it with 1 minute of rebuttal. So if I may begin. Prince George has filed comments in this case and supplemental comments and exceptions to the revised recommended decision, addressing a number of issues. But the primary one, and the one that I want to address today, is the question of the impact that this proposed program at Anne Arundel would have on Prince George's Health Center. Prince George's Hospital Center is the major provider of healthcare services in the county and has been for the last century. It has the only cardiac surgery program in Prince George's County. This commission recently approved Dimensions' applications to relocate the health center to a new facility to be constructed in Largo. The estimated total project cost of that is approximately $543 million, including county and state funding. The project is unique, and it's much needed in the county. It's a collaboration of county and state government together with University of Maryland Medical System and medical schools to provide the citizens of Prince George's County and Southern Maryland with essential health services. A major component of those services is cardiac surgery services. The state health plan, which is seen in Comar, requires an applicant, Anne Arundel in this instance, to provide an analysis of the impact of their proposed program on existing programs. Anne Arundel did not do that in this case with regard to Prince George's. Interestingly, it did it with regard to other programs, but not Prince George's. The reviewer did not ask for or require that Anne Arundel do that. In the supplemental filing that Prince George's filed, we showed that Prince George's now meets the volume and quality criteria to require that very impact analysis. Still, Anne Arundel has not provided it. And in the proposed recommended decision, the reviewer ignored the evidence that Prince George's had provided and decided that there would be no negative impact on Prince George's based on a total absence of evidence, frankly, in the record. His reasoning was, as has been mentioned, there are enough cases for everybody to get to 200, and there's enough to go around, so without any impact analysis at all, approved the project at Anne Arundel. The state health plan requires, specifically in this instance, that an applicant demonstrate that other providers will not be negatively impacted to the degree that will reduce a program with 100 to 199 cardiac surgery cases to less than 100. The general review criteria requires that an analysis be provided with respect to the impact on existing programs. clearly the state health plan gives some deference to the existing programs that are in the region. In this case, Anne Arundel has not done that. As of this morning, Commissioner Canio confirmed his findings, both in allowing the supplemental comments and in his revised recommended decision, that Prince George's does have the requisite volume and quality ratings to be entitled to this analysis required in the state health plan. So that is really not an issue at anymore in this case. The fact of the matter is it's not an issue because Anne Arundel did not contest it in a timely fashion, but at the same time, Anne Arundel in its application has not provided you or the reviewer with an analysis of the impact. We have. The first of the slides that you have is a map taken from Anne Arundel's application on page 131 of its proposed projected service area. And what you will see immediately from that and from the application is that the program at Anne Arundel is intended to draw off 1/2 of the geographical service area of Prince George's existing program. And it is intended to compete for shifting cases from the DC hospitals to it. This will put the still developing program at Prince George's and the new program in jeopardy. It puts at risk one of the essential components of that program. This is the very sort of impact that the state health plan was intended to prevent. We provided to the commissioners another table in our comments. This is table 2 in our initial comments that shows to some extent the overlap. This displays the cases that Prince George's did in fiscal year 2015, 85 cardiac surgery cases. It displays them in descending order by zip code and highlights the zip codes that overlap with Anne Arundel's proposed service area. It's easy even for a lawyer, who doesn't do statistics all the time, to see that almost 46% of the cases from the zip codes in the proposed service area defined by Anne Arundel County come from the zip codes currently served by Prince George's County. Yet Anne Arundel saw no need to analyze that impact. Anne Arundel also says it intends to draw cardiac surgery cases from 3 major DC hospitals and from Virginia hospitals. There are approximately 372 patients in fiscal year 2012 from Prince George's County who were receiving care in those hospitals. Those patients made up approximately 75% of the Prince George's County cardiac surgery cases in that year. Anne Arundel's application projects a shift of 233 cases from those 3 hospitals to Anne Arundel's new program. Well, now, not all of those 233 cases projected by Anne Arundel to shift to their new program are necessarily Prince George's County residents, but it's safe to assume that a fair number of them are. The important thing to keep in mind is that the burden in this case is not on Prince George's to show you how many of them would have been Prince George's residents. The burden is on the applicant to show the impact of its program, and that it has not done. With regard to the financial impact, COMAR requires that an applicant show the financial impact on other existing programs. In this case, Prince George's has made a significant investment in physician recruitment and training and requires continued growth of its cardiac surgery cases to offset the $4.8 million of program fixed costs and get a return on the capital investment that has made it possible for it to provide the cardiac surgery services it now provides. If you apply the projections adopted by the Anne Arundel proposal in their application, you show a significant loss of cardiac surgery cases for Prince George's. During the first 6 months of calendar year 2015, 29 of Prince George's 58 cardiac cases, 50% of them, were performed on patients from Prince George's County zip codes that now fall in the Anne Arundel proposal. So we have a table, one more table from our comments that shows this. And what it shows is that if you take Anne Arundel's projections and you apply them to their projected market share, these are the reductions in Prince George's discharges. Now, those numbers may not look large, but when you look at them as a percentage of the Prince George's cases, they range from 25.86% to 39.65% of the total cases being done at Prince George's. I would submit to you that a reduction of 25 to almost 40% of the cases is a significant impact and will jeopardize the financial feasibility. The last 3 slides, because I'm out of time, I think, or virtually out of time, are analyses of, we tried to figure out if you use Commissioner Canio's alternative method to calculate the impact. These show how that methodology underestimates the impact on Prince George's. And we would ask that this proposed program not be approved because it can have only a detrimental effect on the Prince George's program. When this commission has just approved the new program at Prince George's, we ask that you not undercut that program by allowing a program that will have a detrimental effect, especially where, as the commissioner and reviewer has shown, that the existing program, Prince George's, is entitled to have that impact analysis, and it simply has not been done. Thank you.
Thank you, Ms. McSherry. I do want to mention that the materials have been emailed to Commissioner O'Connor, who's on the phone, so he has the materials as well. Next, we've got Mr. Brennan.
Madam Chairwoman, members of the Commission. My name is John Brennan. I'm here representing MedStar and its MedStar facilities. There are a number of representatives of MedStar here today. I'd like to particularly point out Dr. Stuart Sides and Dr. Paul Corso from our cardiac surgery program, who are here taking an eager interest in this project. My associate counsel, Stephanie Willis, is currently passing out a very, very simple handout. We will also provide that to counsel for the parties and staff. And once those handouts are completed, I'll begin my presentation.
Do you plan on reserving some of your time for rebuttal?
Yes, ma'am. I would like to reserve a minute at the end for rebuttal. Thank you. Thank you. First time I appeared before this commission, hold on to your chairs, was 1981. And thank you for having me back. I appreciate it after all these years. When the Certificate of Need law started, it was a pretty simple statute. It said that healthcare facilities and new services would be approved if there were a public need for those additional facilities or services. On the way to proving need for a service or a facility, an applicant also had to show that it would be utilized sufficiently to be financially feasible. And so in the old days, as some of you may remember, a hospital, for example, would have to show that X number of beds are needed in a certain area, and that if it got the approval, that it would get to 75% occupancy in the second year. That was the old days. That was the way the Certificate of Need law started, with a focus on public need. And it's still that way today, ladies and gentlemen. Despite the head fake here with regard to what the issue is in this case, the issue is not whether one or both of the applicants might meet the minimum volume standard. That is a standard. The issue is whether or not there is an unmet public need for an additional cardiac surgery service in this area. The answer is no. And let me explain to you how this first effort to employ this particular chapter got bollocksed up in this review process. If you will turn to your first tab in the handout, that is a tab that shows you what the review criteria are that relate to cardiac surgery services. You will see there that there is a review criterion related to the state health plan. It talks about an application having to meet the state health plan standards. The next separate review criterion is the need criterion. It says to an applicant, if there is a need analysis in the state health plan, you can go ahead and use it. But if there isn't a need analysis in the state health plan, you have to show unmet public need using your own methodology. Plain and simple, dichotomy. Meet the state health plan standards, show public need, just like the old days. Now please flip to tab 2. This is the state health plan that we are talking about. And you will see 0.05, the very title of 0.05 is standards to be considered in the review of cardiac surgery application, standards. So immediately you think back to which criterion that talks about. It talks about the state health plan standards criterion. And the very first standard that's listed at A1 under this chapter is the minimum volume standard. Now, both of the applicants and apparently the reviewer would suggest to you and say, if an applicant can meet the minimum volume standard, that applicant is home free. There doesn't need to be a need. And so if a pie is a pie of 10, that would be existing demand. If an applicant can say that I'm going to take 2 of the 10, that's enough. The applicant doesn't need to show that there's a need for 12. That's according to the reviewer and the applicant. There's no need, if you will, to show unmet need. That's not the law. That's not what this chapter says. Because when you look down the chapter to 5, which says need as its title, you'll see the minimum volume standard repeated under need, but then you will also see quite clearly that the plan tells the applicant that it needs to come up with a need analysis because there is no need analysis in the plan. And the need analysis is set forth quite clearly as to what the applicant needs to do, needs to look at utilization, needs to look at the utilization in the region, even shows the applicant and the reviewer what data must be used to do that. It's the data in tab 3. And so what happened in this case, folks, is this. The applicants, eager to get approved, the reviewer, perhaps confused about the difference between minimum volume standard and unmet need, all flew like moths to the minimum volume standard. That's all that counts. If we can pull 200 surgeries away from the existing pie, we ought to get approved. That's not what the chapter says. That's not what the review criteria says. There needs to be an unmet need. One final point here to show the confusion that exists with regard to this issue. The reviewer came up with a methodology, the revised forecast methodology. But then the reviewer applied that to the minimum volume standard. He didn't come up with a methodology to show unmet need. He used it for the minimum volume standard, the head fake that these applicants are using to try to tell you that there's an unmet need. So that was a flaw in the review process, not considering whether there's an unmet need, and then coming up with a methodology to look at the minimum volume standard, not need. And then the reviewer did one more thing that is a due process problem. You'll see in the chapter where it says under need that the data that is to be used in the need analysis is the data that is published under 0.08. That's the data at tab 3. That's the data that was published in February 2015. And if you'll turn to that tab, you'll see that in this publication, you, the commission, said, these are the data, these are the utilization projections, this is the framework that will be used in the next review cycle until new data is published in the register. It's as clear as a bell if you'll read that language. The data has to be published in the register before it's used. The framework has to be extended. That's exactly what the February register says. That's exactly what the reviewer did not do. The reviewer decided that he was going to go out to 2020. He was going to collect new data. He was going to extend the utilization review process in the register, and he wasn't going to publish it. That's a due process problem. An applicant, a potential applicant like MedStar, sitting there at the beginning of this process, looking at the data that would be used, thought, look at that trend line. Cardiac surgery going down 3,000 to 2,600 over 10 years. We're not filing. But then, in the middle of review, new data is used, not published in the register. So there's lots of reasons why this was a false start, so to speak, in using this chapter. The impact on existing providers, I don't know how you get over that one. But ultimately, this commission is to identify unmet need. There is no identification of any unmet need that either of these applicants would meet in this case, notwithstanding all the fuss and fight about the minimum volume standard. And that's our MedStar's position. We'll be back later. I've got a couple more things to say. Thank you.
Thank you very much. So now we have Mr. Rosen. Welcome.
Good afternoon, everybody. Just little old me after all these other folks coming after us. First, I'd also like to introduce some of the folks who were here with us. Tori Bayless is the president and CEO of Anne Arundel Medical Center. David Florin is our general counsel. Barbara Jacobs is our chief nursing officer. Malik Jassi is our chief operating officer. Bob Riley is our CFO. Dr. Jerry Siegel is the medical director of cardiovascular services. And Paula Weiderlight is our chief strategy officer. As you know, we also have a partner in this. Surgeons at Anne Arundel Medical Center will be provided by Johns Hopkins. And with us today is Ron Peterson, the president of Johns Hopkins Health System. Also John Conti, the professor of surgery, division of cardiac surgery from Hopkins is here. John Colmers, the senior VP of healthcare transformation and strategic planning. And Dr. Robert Higgins is the William Stewart Halstead professor, director of the Department of Surgery at Hopkins. We have many other folks here with us too, members of our board of directors, important patients who have been through our cardiac program, but the group that I'm introducing, I just have introduced. We also have a handout, which we have distributed. There's 2 foam boards, and council also has our handout. Okay. What I'm going to do is 3 things. I'm going to talk about Anne Arundel Medical Center. I'm going to talk about the exceptions, and then I am going to ask all of you commissioners to adopt Commissioner Tanio's recommended decision granting a certificate of need to Anne Arundel Medical Center and denying the application of BWMC because we met every one of the standards and BWMC did not. Let's start with a little just geographic orientation. That's in the handout. You'll see that's Anne Arundel Medical Center. It is in Annapolis. You'll also notice that it's 30 miles away from Baltimore, 30 miles away from Washington, D.C., and obviously the open heart surgery programs are clustered in the metropolitan area today. They're clustered in Baltimore and they're clustered in D.C. Also on the map, you'll see is the existing Prince George's Hospital, and here in Largo is where the new Prince George's Hospital will be going, and it's 23, 24 miles away from Anne Arundel Medical Center. Anne Arundel Medical Center is the 3rd busiest hospital in the state. There are only 2 hospitals that have more admissions than Anne Arundel Medical Center. And for example, University of Maryland downtown has less admissions than Anne Arundel Medical Center. Anne Arundel County itself is the most populous county in the whole state of Maryland without an open heart surgery program. In fact, Anne Arundel County is one of the most populous counties in the whole country without an open heart surgery program. Notwithstanding that we don't have an open heart surgery program, we have a very robust cardiac program. Jonathan, can you put the other, I'm sorry, I should have introduced Jonathan Montgomery, my partner in this review. Thank you, Jonathan.
What you can see here, this blue line on the left, these are the over 200 patients that every year are being referred from Anne Arundel Medical Center to open heart surgery programs, either for open heart surgery or to be evaluated for open heart surgery. In our application, we've estimated conservatively that a touch under 200 of those would actually stay at Anne Arundel Medical Center if we had a program. That's because some people go get evaluated and don't have open heart surgery. And also some people, the acuity is, is so high that they really should go to an academic medical center. So in comparison, this isn't our estimate. This is from BWMC's own application. They did the same type of analysis, and they believe they would retain a little under 100 of their patients that they're referring out now. And what Commissioner Tanio did, reached the conclusion that it simply wasn't credible to believe that actually BWMC would double that number from under 100 to over 200. But what's most important to this aren't these numbers. It's to remember these are people. These are real people. 200, over 200 people every year are coming to Anne Arundel Medical Center, and they are being transferred by helicopter, ambulance, however, to other centers when they don't need to be. They're being separated from their families during that time. As you all know, every time there's a handoff in a medical center, there's a possibility for a problem. The aftercare is disjointed. You're having surgery one place and your aftercare another. There's also simply delay in trying to get the patient to the next center. We have documented in the record, unfortunately, we get turned down. We call, we're told our patient has the wrong insurance. We call and we're told the ICU is too busy. We can't take your patient. We've documented in the record that sometimes these delays don't have bad consequences. Unfortunately, in the record, we've also documented there have been the most serious consequence as a result of these delays. You have the power today to fix that. With our partner, because we've joined Johns Hopkins Medicine to provide the surgeons, and if you grant this certificate of need for open heart surgery, those over 200 patients can stay. There won't be delay. On top of that, we will be one of the lowest cost facilities, open heart surgery facilities in the state. That will save patients and third-party payers millions of dollars every year. Also, by drawing patients from Washington back to Maryland at a lower cost, we'll be helping the Health Services Cost Review Commission meet the very hard test it has to meet to maintain its waiver from the federal Medicare program. Let me talk about the exception. The most important thing I think you should remember about what you just heard about the exceptions from the other parties is what you didn't hear. Nobody said to you, our program won't be successful. Nobody. Instead, these were unpersuasive, last-ditch arguments that asked you to suspend all common sense. And we suggest you reject all of the exceptions. I will respond to three or four of them, depending on time. First, BWMC is concerned that Commissioner Tanio applied a market analysis to test whether or not BWMC really would make the 200. Notwithstanding that there was a market analysis in ours, and notwithstanding there was a market analysis in BWMC, somehow by Commissioner Tanio considering, is this credible or not, and looking at the market, there was something wrong with it. In addition, the next argument, Prince George's County. There are over 600 patients in Prince George's County in need of open heart surgery every year, another 600 in Anne Arundel County. There are plenty of patients for everyone for both of these programs to flourish. With respect to economic feasibility, There are two prongs to the standard of economic feasibility. The first prong is that our cardiac revenue has to exceed our cardiac expenses, and the second is that the program does not jeopardize the financial feasibility of the hospital. Our cardiac revenue will exceed our cardiac expenses. The only thing that the 50% market share provision from Nextdoor does is it says to Anne Arundel Medical Center, look, when you get all this new revenue, you're going to have to do one of two things. You're either going to have to lower some of your prices on some of your other services, or do exactly what the Health Services Cost Review Commission wants you to do, and that is take care of the people of Anne Arundel County. Do population health. Get some of those frequent flyers in your emergency room, reach out to them, get them better. Go after the diabetic folks and get them better so they don't come back. Don't have complications at the hospital. Do your job, and there's plenty of revenue there. And obviously, in either of those cases, the economic feasibility of Anne Arundel Medical Center is not jeopardized in the least. With respect to the need example, perhaps if this was 1981, MedStar's counsel would be right. This isn't 1981. Your regulations say in Section 6, and this is need, this is what you have to prove for need under your regulations, an applicant shall demonstrate that a new or relocated program can generate at least 200 cardiac cases. That's the need. That's the need right there, is getting that care to those folks. I should have said, by the way, that the way we get from 190 over 200, there's 100 cases that bypass us now that go straight to Hopkins from the people in Anne Arundel County. And many of those will now come to us, take us easily over the 200, because now we have the Hopkins surgeons also. I suggest to you this is the triple aim. This is your opportunity to foster the triple aim. This is a better patient experience. This is high quality care, and this is doing it at a lower cost. For all of these reasons, on behalf of Anne Arundel Medical Center and Johns Hopkins, I urge you to adopt Commissioner Tanio's recommended decision, grant us the certificate of need to take care of those folks, and deny BWMC's application. Thank you very much.
Thank you, Mr. Rosen. So there is now time for rebuttal by Mr. Dame.
Thank you, Commissioner Stallworth.
You've got a minute and a half.
Thank you. I'd like to, in my minute and a half, address some of the points that Mr. Rosen made. First, the chart that he's showing you only shows the cardiac cath volume. It's only one element of the minimum volume assessment that BWMC and Anne Arundel conducted. It ignores, as the reviewer did, the substantial volume that will come from the University of Maryland Medical Center, which is part of the fully integrated system. Secondly, I'd like to note that Anne Arundel's program depends entirely on pulling cases from DC, principally from MedStar Washington Hospital Center. In fact, they submitted in their analysis that they will draw cases from a cardiologist group that's employed by MedStar. None of those doctors signed the letter, but they're counting on 57 cases coming from those doctors. BWMC is a much safer bet to reach its minimum volume because, as I noted, it will be drawing 150 cases each year from the University of Maryland Medical Center. And what's important in this review is that it was never given a shot. The minimum volume standard, and I will say that over 30 years, only one other hospital has been kicked out of minimum volume. That was Maryland General Hospital in 1990. We were knocked out, or recommended to be knocked out on minimum volume, so there was no comparative review here. There's a comparative review standard. That was not applied at all here. We were taken out of the game before there was any real assessment of these two programs. Thank you for your consideration. We ask that you reject the recommended decision.
Thank you. Ms. Sherry? Ms. Sherry?
I don't know, 20 seconds?
A minute.
A minute?
A minute.
Yes. I could go crazy with a minute. Thank you very much. And I will keep it brief because our point is simple. Our point is that the state health plan requires an impact analysis. One was not done. Therefore, Anne Arundel must be denied because they failed to meet the state health health plan requirements. To say that there are over 600 patients in Prince George's County and over 600 patients in Anne Arundel County, and therefore there are plenty, is not an impact analysis. That simply says there are lots of patients maybe around. It doesn't say what the existence of a program at Anne Arundel Medical Center will do to the existing program at Prince George's Medical Center. And that's what needed to have been done, was not done, and therefore the application must be denied. Thank you. If I have 10 seconds. Hot diggity. Forgot one thing, because I wanted to point out, I mentioned the 20 to 40% reduction. If you take the 110 cases that we had, that we showed in our supplemental comments, and reduce that by 40, it does in fact reduce Prince George's to less than the 100 cases. And that's the impact that we've shown Anne Arundel has not. Thank you.
Mr. Brennan, available for rebuttal comments? Mr. Brennan, you too have a minute.
Thank you. Mr. Rosen, there's one thing that hasn't changed since 1981, and that's the Certificate of Need Law. The Certificate of Need Law in the state of Maryland was enacted in 1978, and at its core, the CON law was to look at whether or not there was a public need for additional services. That has not changed, and you can't change it. Nor can Mr. Rosen, nor can any of us. It's the legislature that can change that. And so what I would ask you to do today, if there is any debate about this, I would like the commission to step at the issue of whether or not you think that if someone meets the minimum volume standard, they have identified an unmet public need. I'd like to hear your answer to that. I contend that that's not consistent with the law. I contend that an applicant must do both, meet the minimum volume standard, and show there's an unmet need. And tab 1 in front of you makes that very clear. The need analysis is a separate requirement, which is addressed separately both in the criteria and in the state health plan. All that happens when the minimum volume standard is mentioned under need is that the plan has dragged down the standard that it is already presented above and put it under need, and then talks about the need analysis that must be required.
Thank you, Mr. Brennan.
Thank you.
Commissioner Tanu?
I've read the written exceptions, and I've listened carefully to the arguments at today's hearing. My recommendation remains unchanged. As detailed in my revised recommended decision, I recommend that the Commission award Anne Arundel Medical Center a CON to establish cardiac surgery services. In my initial remarks, I note the positive impact that either of the proposed programs would have on costs to the healthcare delivery system in Maryland. However, the Commission and I, as the reviewer, must balance the potential benefits that may be obtained through increasing the number of cardiac surgery programs against the need to move carefully and cautiously in expanding such programs. As noted in the background section of my revised recommended decision, and noted by the interested parties in their arguments, cardiac surgery case volume has declined by about 30% in Maryland between 2000 and 2011. While volume has rebounded about 13% since 2011, the overall trend suggests that at this time it is prudent to approve only one new cardiac surgery program, and that program should be proposed in AAMC's application, which met all the applicable standards and criteria. That's just a part of context. We've had several discussions in the Commission over time about the difference between models and what has actually happened in reality. And so that context of prudence and caution is appropriate here. I've tried to find the appropriate balance among considerations of needs for the proposed new cardiac surgery programs and the impact of the proposed program. I considered the impact on the cost of care, on access to care, on the quality of care, and on the existing providers of cardiac surgery. So let me give a couple points of context around the 2014 cardiac surgery chapter. So I note that in recent years, Maryland has reconfigured its system of regulatory oversight for cardiac surgery and PCI services. This process was strongly aided by the advice and guidance of two panels, including the MHCC's Clinical Advisory Group comprised of regional and national experts, which played a primary role in the development of the standards in the current cardiac surgery chapter of the State Health Plan. It is important to note that the 2014 cardiac surgery chapter creates opportunities for consideration of new programs that did not exist in previous chapters. Earlier cardiac surgery chapters used regional case projections and other rules as a basis of determining whether applications would be accepted. Specifically, the 2014 chapter provides that an applicant may establish a cardiac surgery if it can show that it will meet the required minimum volume of cardiac surgery cases and that it complies with other standards and criteria, including the new program not have an impact of a specified magnitude on existing providers. There is no barrier to filing an application in that surgery chapter, and the specifics around the need are in page 73 of the revised recommended decision. So now I would like to address the rationale behind my recommendation with particular emphasis on 5 issues, all of which were raised in the exception. So the impact on existing providers, particularly on Prince George's Hospital Center, my projection of cardiac surgery volume that each applicant is likely to achieve, need, access, financial feasibility, and the Commission's intent in adopting the 2014 cardiac surgery chapter, and finally, financial impact. So let's start on impact on existing programs. I concluded that the approval of the cardiac surgery program at AAMC would not cause any existing cardiac surgery program to fall below acceptable case volume. I found that the program at Prince George's Hospital Center, which is currently performing over 100 cardiac surgeries annually, would not drop below an annual level of 100 cases. That is the relevant standard at issue in this review. To give context, Prince George's Hospital Center performance of over 100 cardiac surgery cases in 2015 and 16 under its operation by the University of Maryland Medical System represents a remarkable turnaround for the hospital, which had performed an average of fewer than 18 cardiac surgery cases per year in the 4 preceding years. And at the time when the CONs were initially submitted, cases, I think in 2014, were 29 cases at the time. The only quantitative approach which takes exception on this issue in the written exception dimensions applied the med-surgical area model and the normative market share assumption. And their analysis showed that it may prevent Prince George's Hospital from reaching an annual volume of 200 cases, but the applicable test and the impact standard is the 100 case level. So that being said, if the proposed cardiac surgery program at AAMC is established, both the AAMC program and the program at Prince George's Hospital Center and its replacement hospital approved by the Commission in October could meet the 200 case volume level. While the cardiac surgery scepter requires a new program to meet the 200 level, it does not require an existing program to do so. When the new Prince George's Regional Medical Center is completed in Largo, every expectation is that it'll be a much stronger player under the continued operation by the University of Maryland Medical System. This development, made possible by a large public investment, will make it much more likely that the Prince George's Hospital Center will be able to compete effectively for a reasonable share of the Maryland market, particularly with District of Columbia cardiac surgery providers. Since Prince George's Hospital Center is currently performing over 100 cardiac surgery cases annually, the incremental market share gains it needs to reach the desired case volume are small relative to the size of the metropolitan Washington, D.C. market in which it operates. any failure of Prince George's Hospital Center and the University of Maryland Medical System to maintain the revival of the Prince George's Hospital Center cardiac surgery would likely result from failure to bring Prince George's County residents migrating primarily to Washington, D.C. hospitals back to the only Maryland hospital providing this service in Prince George's County. I believe this is a much more critical factor for the future of Prince George's program than the increment of patients from the county who may turn to Anne Arundel Medical Center for cardiac surgery services. The bleak impact scenarios presented by the parties taking exception suggest that Prince George's Hospital Center has reached or nearly reached its peak level of performance, which has demonstrated a remarkable turnaround in the last 2 years and cannot continue to grow. I know that all commissioners hope that this is incorrect. I concluded this will not be the case, particularly if the hospital, under the leadership of the University of Maryland Medical System, makes the needed efforts to encourage patients to stay in Prince George's County for cardiac surgery rather than travel to Washington, D.C. hospitals. And then finally, in this area, it is not the role of MHCC to create barriers to competition through CON. This is a principle that we have discussed multiple times in the past few years. Rather, the health system benefits from healthy competition as envisioned in the 2014 cardiac surgery chapter. The next discussion will be on my projection of case volume. AAMC and BWMC each projected the volume of cardiac surgery cases that it would perform if its application were approved, as is required by the cardiac surgery chapter. And models are models. I found that while each applicant presented projections that were consistent with the guidance in the chapter, each made overly optimistic assumptions regarding both its proposed service area and its achievable market share in its self-defined service area. So for this reason, I arrived at an alternative, consistent, and more conservative approach to projecting case volume for each applicant. This is permitted under the cardiac surgery chapter, and importantly, it allowed me to compare both cases more directly and consistently. It is important to note that I did not, as BWMC claims, replace a model found in the cardiac surgery chapter with an alternative model because no such model is in the chapter. Instead, in my analysis, I used the same guidance in the cardiac surgery chapter that each applicant used in addressing the minimum volume and need standards. I based this analysis on each applicant's hospital's actual medical surgical service area, and to make the analysis more realistic, I used assumptions about market share and the relevance of these service areas that were based on the actual experience of most similar Maryland cardiac surgery hospitals. I undertook this analysis to test the strength of each of the applicant's assumptions and that it would meet the minimum care volume level based on actual experience in Maryland. I explicitly recognized that in both cases, the existence of partnering major cardiac surgery hospitals and surgeons working at those hospitals could alter the achievable market share of the applicants in ways that were not addressed by the analysis. And my analysis showed that if only the AAMC application were approved, it would be able to achieve the average results seen in the 3 comparison group hospital service areas and meet the minimum surgery case volume requirement. That same analysis showed that if the commission approved only BWMC's application, it could not meet the minimum volume requirement. Given those issues around the existence of partnering hospitals and the limitations on that model to fully address that, we also did a scenario analysis of both programs approved to stress test the scenario if both applicants were approved. And in those, that showed, I believe, the case for prudence and conservatism in only approving one applicant. BWMC implies that the regional case forecast model of the cardiac surgery chapter is the official model that I should have used in my analysis, and simply stated this is incorrect. The regional case forecast does not establish that a hospital can meet either the minimum volume or need standards of the chapter. The forecast rather comes into play only one way when considering the standards. That forecast establishes whether recent trends in the demand for cardiac surgery at the regional level indicate growth or decline in use. An applicant must address this trend in responding to these standards. Notably, the cardiac surgery standard instructs an applicant to do three important things. One, to project demand for cardiac surgery services by its hospital service area population, not merely the 11 counties in the region. Two is to analyze the market share it expects to capture in the hospital service area. And three, to establish the reasonableness of its assumptions in defining its proposed service area. My approach is a valid way to establish the reasonableness of the assumptions made by each applicant. And I note that both applicants have bases of support that theoretically could allow either hospital or both hospitals to achieve the minimum surgery case volume threshold. My decision to recommend AAMC's proposal was grounded in my conclusion that it is the stronger applicant and could reach the minimum volume standard based on more conservative assumptions shown in the observed experience of similar Maryland cardiac surgery hospitals. Let me bring up the issue of access. On that issue, I note that the cardiac surgery chapter provides that an applicant may seek to justify establishment of cardiac surgery services in whole or in part based on inadequate access to cardiac surgery services in a health planning region. AAMC sought in part to justify its proposed program on the reduction in travel time to cardiac surgery services for patients in the service area, many of whom migrate to Washington, D.C. hospitals for the service. I found that a new program at AAMC will improve access to the service by patients and families, particularly those who live in Upper Shore County, but also in Anne Arundel County. I found that a cardiac program at AAMC would improve access to this service for patients and would be a benefit of the program, which was a secondary factor underlying my recommendation. And in particular, I noted that a cardiac surgery program located near Annapolis will improve travel time access for more Maryland residents than would the addition of a program in Glen Burnie. So let's turn now to the complex issue of financial feasibility. This gets us into a discussion of regulatory purpose and the history of both the 2014 cardiac surgery chapter and its financial feasibility standard. So in adopting the 2014 cardiac surgery chapter, the Commission opened the possibility of new providers of cardiac surgery services in Maryland. A hospital that wanted to establish cardiac surgery services would have to show that it could perform a minimum volume of cardiac surgery services and that would meet other requirements. For the first time, all cardiac surgery programs in Maryland, including new programs, would also have to maintain certain quality standards or to face possible closure. The Commission was in fact making the establishment of a new cardiac surgery program easier than it had in the past, knowing that quality would be assured or the program would have to close. So there were deliberate discussions about lowering the barriers to entry. The 2014 regulatory change results in part from the conclusion by the Commission's expert cardiac advisory group in the medical literature that volume no longer equated with quality, and that a lower volume program could be a high quality program. And this is in fact borne out by the experience in the cardiac surgery program at Prince George's Hospital Center, which recently received a 3-star composite rating, the highest rating from the Society of Thoracic Surgeons, even though it performed only slightly over 100 cardiac surgery cases. As parties taking exceptions have pointed out, the financial feasibility standard of the cardiac surgery chapter provides that a new cardiac surgery program, quote, shall be financially feasible and shall not jeopardize the financial viability of the hospital, end quote, and that an applicant demonstrates that, quote, within 3 years or less of initiating a new cardiac surgery program, it will generate excess revenues over total expenses for cardiac surgery. The financial feasibility standard must be read as a whole, keeping both in mind common sense and the Commission's intent in adopting the 2014 cardiac surgery chapter. It is critical to understand that I found that each program at its projected charge levels would, from a conventional accounting perspective, be able to generate cardiac surgery revenue that would exceed expenses in providing the service. No party taking exceptions about any claims about the overarching provision has made any claims about that overarching provision in the financial feasibility standard. It is undisputed that the establishment of the cardiac surgery program would not jeopardize the financial viability of either applicant hospital. But now this gets us to the subsidiary portion of the standard regarding the generation of revenue over expenses under the current payment model. So it's essential to think about time here, because when the Commission proposed the adoption of the 2014 cardiac surgery chapter, the current position of the HSCRC had not been established. The manner in which market shifts were recognized in adopting and updating hospital budgets could only be viewed as established by the HSCRC for the first time in fiscal year 2016, given that policy was used in the update of hospitals' global budgets at that time. However, it was only in August of 2016 that the HSCRC formally stated that the Maryland hospital payment model in treating shifts in volume from one hospital to another would recognize only the variable cost components of the service revenue in the global budget of the hospital to which case shifts. This cost component was established at 50% of the total revenue. Thus, under HSCRC's current policy, as stated in August 2016, the hospital losing a cardiac surgery case would retain 50% of the revenue it would have otherwise received in its global budget, and the receiving hospital actually performing the surgery would only receive 50% of what it would otherwise charge in its global budget. This means that the hospital losing cases would need to adjust its charges upwards to realign revenue with its global budget cap, and the hospital acquiring the case would reduce charges to stay within its global budget. So for these reasons, I concluded in light of the Commission's intent that the initial principle of the financial feasibility standard should apply as opposed to the subsidiary provision. Otherwise, just given the mathematical application, a new cardiac surgery program could never be established in Maryland under the volumes that a new program could reasonably be expected to achieve. AAMC has shown that it's able to establish cardiac surgery services on a financially feasible basis that will not jeopardize the financial viability of the hospital, operating in conformance with the global budget agreement with HSCRC. As I stated in my revised recommended decision, this interpretation of the standard is in accordance with the Commission's intent in adopting the 2014 standard and with its mission and legislative directive to assure access to quality health care at a reasonable cost to patients and to the healthcare delivery system. Let's talk about need. So need for a proposed project is always an issue in a CON review, and different methods for determining need are set out in various chapters of the state health plan. The applicable need analysis in this review is the need standard that was set forth in the 2014 chapter, the cardiac surgery chapter, which provides that a demonstration of a minimum case volume at an institutional service level is the core basis for finding of project need. This need standard is not divorced from the other considerations required for project approval. AAMC demonstrated that its proposed cardiac surgery program can achieve the required case volume found in that standard and meet all other requirements. BWMC did not. MedStar in particular looks not to the 2014 cardiac surgery chapter, but to the past, to earlier iterations of the chapter which contain more direct mathematical formulations of how the Commission would find a population need for additional cardiac surgery capacity. The Commission rejected that approach when it adopted the 2014 cardiac surgery chapter and also has changed its approach with some of the other facilities and services that it regulates. there's been a theme of looking to improve competition. In 2014, the Commission made a conscious decision to adopt the cardiac surgery chapter that creates opportunities for it to consider applications to establish new cardiac surgery programs that will provide quality cardiac delivery services and benefit Maryland residents and the healthcare delivery system. So in summary, Anne Arundel Medical Center met all the standards and criteria required to establish a cardiac surgery program. It made the stronger case of the two applicants for developing a program that will operate in an appropriate case volume, and it's shown that it'll be able to deliver cardiac surgery services that are effective and of high quality. The new cardiac surgery program at AAMC will not have an impact on existing cardiac surgery providers that warrants denial of this single application. AAMC will be able to offer the services while also maintaining profitability and long-term viability. And its proposed program will also provide for a greater improvement in access and a decrease in travel time, particularly for the residents of the Upper Shore County. The Commission has the opportunity today to approve a new cardiac surgery program that will result in substantial savings to the healthcare delivery system and the lowering of charges for cardiac surgery for residents of the Baltimore and the Upper Shore region. This recommendation does not preclude BWMC from coming back to the MHCC at a future time once there is concrete evidence of the impact on the movement of cardiac surgery volumes from a high-cost center to a lower-cost center on cost, quality, and access. So I move that the Commission adopt my revised recommended decision as its decision and approve the establishment of cardiac surgery services at Anne Arundel Medical Center with the 4 conditions that I have recommended, and that the Commission deny the application of the University of Maryland, Baltimore, Washington Medical Center.
So the motion's on the table. Anyone second? Thank you, Commissioner Moffitt. So we'll go ahead and open this for discussion. Commissioner, comments from Commissioner? Questions? Go ahead, Commissioner Moffitt.
I want to thank you, Chairman Tanio, for a comprehensive evaluation of the circumstances that we find ourselves in, and I want to commend you for the excellent work you have done on a very difficult and challenging project. I have some sympathy for the kind of work you've had to do. You have to balance, in this area, it's a question of balancing a number of goods. Our responsibility as a commission is to do the very best we can to meet the triple aim, to improve the patient experience, to improve the cost of care, and to improve the quality of care that is delivered to our fellow citizens. That is the overriding responsibility and the broad charter that is given to the members of this commission who are appointed by the governor for that purpose and confirmed for that purpose by our state senate. I will say up front that I am very, I've read all of your paperwork, and I think you have presented a balanced and thoughtful presentation of the issue, and I think your resolution is thoughtful. I would just mention 2 things in this circumstance. One is that I don't think there's anybody on the commission who shares more a concern about the welfare of the people of Prince George's County, because I have done an extensive study of their circumstances. And one of the great decisions, I think, of this commission was the creation of the Prince George's Regional Medical Center, which holds such tremendous potential for the improvement of the health of our citizens in Prince George's County. The location in Largo is one of the great decisions that the people in Prince George's County made, because what it will do is it will give the Prince George's County Regional Medical Center an opportunity to reverse the out-migration from Prince George's County to Washington. And for Prince George's County, the number one job, it seems to me, is to recapture, as they have said in their own presentation, to recapture lost patient base, and at the same time, with this commitment that they have demonstrated to improve primary care and develop a robust network of primary care in Prince George's County to create another source of revenue, a stronger patient base for the Prince George's County Regional Medical Center. So I'm excited about that. I do not think that the creation of a good, solid program, a high-quality performing program in Anne Arundel Medical Center in any way really jeopardizes the future of such a fine enterprise. And I agree. We, as commissioners, we have looked at this and we have recognized that in that particular case, we had to do what we thought was best, and we certainly did. I think the future is very bright for Prince George's County. I do not see the development of a quality program at all threatening the emergence of another quality program, which has such great promise, and which this commission has so strongly endorsed. The other concern that I have in all of this is the whole question of the access to care. We need to make sure that all of our fellow citizens have the widest access to care. And I just want to mention that in this particular case, the Maryland State Legislature has enacted legislation for us to look into the problems of access to quality of care for our citizens on the Eastern Shore. The Eastern Shore is an area where we have to concern ourselves with the access to care, and certainly, this is an ongoing process right now. But one of the things that motivate me to support this motion is my deep concern for the our fellow citizens on the Eastern Shore. Their circumstances are certainly one of the strongest reasons I think that we should have to approve the creation of a first-rate cardiac surgery center in Anne Arundel. Mr. Chairman, congratulations on a job well done. I think it's an outstanding contribution of public service. I know that this has been difficult. It is always difficult to balance competing goods, and that's what we have to have. That is exactly what we have done in this particular case. Thank you, Madam Chairman.
Thank you, Commissioner Moffitt. Other comments from the Commissioner? Go ahead, Commissioner Sargent.
I just wanted to thank you for the very thorough review. I think hopefully no one will tweet about you as a result of this. But I just wanted to remind, there's obviously some heat involved. You can hear in the various arguments presented that we're a part-time commission of citizens who volunteer to do this.
I'm reminded by the sounds in the air that we also have Commissioner O'Connor on the phone. So I just wanted to check to see if Commissioner O'Connor, you have any comments or questions? Okay. Hearing none. Further discussion? Okay. So I guess we'll go ahead and call for the vote. So what we'd like to do is to make sure that we're very clear about the vote. So if you would raise your hand, so all those voting in favor, say aye. Please hold your hand. So
Aye. Dr. O'Connor says aye.
Thank you. We hear you. We assume your hand is in the air. All those voting no, nay? Abstention? All right. So with that, the motion is approved. Thank you very much for your work, Chairman Cameo. Incredible amount of volume. I also want to say thank you to everybody here who has come today to engage and to be present. It's a lot of effort on many people's parts, so I wanted to express my appreciation as well.
Yeah, if I could just make a couple quick comments. I think first I would like to really thank the staff. The amount of work and integrity that the staff did in this whole process was phenomenal. And although I've been able to from the chair, quite a bit the work professionalism and value. Really a tremendous assistance in assembling the right fact base, helping to make sure that we were adhering to the guidelines laid out in I appreciate the opportunity to have served the public in doing the CON. I do believe it will create a positive good, and really, we've had a number of CONs in front of us the last few months. So after we do the Cardiac Services Committee review, I would like to share a couple perspectives that are germane to regulatory reform that kind of come from doing these few CONs over the last couple months as the next item after the Cardiac Services Committee review on the agenda. Thanks.
So, thank you for those comments. I will say I appreciate the fact that we can have that discussion about the higher level issues around certificate of need. And we will take a 5-minute break before we resume with today's agenda. Thank you.
Second. Any questions or discussion? Seeing none. All in favor? Aye. Any opposed? All right. The Advisory Services Committee changes is approved.
Thank you.
So we have less people in the room, but we've had here, a set of discussions, a major sort of CON approvals the last, couple of months, and we've also had a public discussion about the legislative agenda a few weeks ago, where really a couple of the core questions that are being raised about the commission is, what's the purpose and organization structure of the two commissions, and how does this tie into, future regulatory reform? And so, what I just wanted to do is just reflection around this CON process that I just went through, but also the other two that have recently been in here. And I think for me, it raises sort of two questions. You're going to only hear questions from me, not necessarily answers. But, I think question number one is CON focused on the right question. And then question number two is CON doing the right thing given the changes in the environment today. And let me just sort of go into those a little bit deeper. So on, CON focused on the right question. As many of you know, I'm passionate about trying to push healthcare delivery system innovation in a way that can achieve the triple aim. Cardiac surgery is big business in Maryland and across the country, and clearly helps a number of people, and the participants in Maryland have outstanding quality. But one of the questions today with cardiac services is that we should be, fixing the plumbing with cardiac surgery, when the data is sort of emerging in a pretty conclusive way that actually creating healthy arteries through a number of different other strategies and reversing disease through lifestyle changes and others could be a superior population health strategy. And so it just, as we reflect upon what kind of things we should be focusing on as a commission, and looking for answers, I think the challenge should be, what kind of energy is going into innovation that can improve the value. I think it's harder for the commission to address this issue of, CON the right question. But I do think that there's a number of things that over the last 2 or 3 years have consistently come on the commission agenda around primary care, around community health, around the consumer data, that gives us potentially the opportunity to sort of ask the question, are we prioritizing the right thing from a health system perspective? And I don't think that we should lose sight of that as we think of what our priorities are. What I want to tie then second is, is CON doing the right things given the changes in the environment today? I do think as I look through the process, I do make a couple comments on all of the different CONs. There is diligence in getting the right facts and following the right process so that we adhere to the spirit of the regulatory structure. But from an administrative cost perspective, it is expensive. If we look at the stacks of paper generated from the CONs, it probably would fill, at least, half of this room. And we haven't estimated the dollars that's come up in other CONs, but I would conservatively estimate you combine all the 3 recent, I think you would get into 7 figures if looking at total stakeholders. And money spent on this area is being taken away from other issues. The discussion that we just had around cost and the waiver we've had, and the all-payer model, we've had that over the last couple of years. We've gotten clarification around that. And I do think now that it's becoming clearer, then the fundamental basis of CON as a tool for cost control to manage supply, I think there are a set of solutions that could be quite different in this new environment, and if done right, could dramatically streamline the CON. The final point I would just sort of make is about the nature and the type of competition. We've had a lot of discussion in these meetings about the nature and type of competition that arise from CON regulation, and I've tried to tie in the conversations over the months. But I think there has been a theme that many commissioners have brought up about a concern is, do the CON rules favor the incumbent? Does it just sort of create barriers to entry that don't allow new entrants and new innovation to kind of come in here? And if you just think about the energy spent on an organization can only spend so much energy. You can spend your energy trying to competitively win the CON process and do all kinds of maneuvering and approaches through that, or it can be around actually driving innovation at the front line. And so these are issues. The cardiac chapter presented an example of, I think, very positive adjustments in the regulation in 2014 that tried to lower the barrier to entry. But I think the real question on the table for us going forward is, can we do more? And I think you can see that even though those intentions were there, they were incremental, it doesn't necessarily remove the whole cost structure out of that, even though you lower the reform. So my question on the table is, are there opportunities for dramatic reforms that could radically streamline the process? I think it's my sincere hope that there is, that the commission won't let that opportunity go. I think there is going to be that opportunity in the conversation we're going to have about the mission of the commission and the org structure that started to be teed up on the legislative agenda, and that we should, as a commission, continue to have that debate and to figure out how we can productively fine-tune our perspective on this issue. So, like I said before, you were going to only get some perspectives and not answers. But I do think that there is an opportunity in this next year to get much more sharp about where the commission wants to go on this and how to shape it. So with that, I'll open it up to comments. Let's just start and go around clockwise.
Okay. A couple of things I'd like to just, again, perspective, and maybe even going from 30,000 feet up to 60. When I think of CON and how it kind of fits, and this is coming from kind of the health economist side of things, it was a tool that was developed originally for a couple of purposes. Certainly more than a couple. There was this traditional kind of stated health planning zone coming out of a certain literature. It was used by policymakers in the era when, let's call it, provider-induced demand was particularly high. And it wasn't just physicians, mostly physicians, but not only physicians, nursing homes, et cetera, et cetera. And it was set up as a way to sort of, you had a fee-for-service environment, regular rules of the market didn't apply, and it was a tool that was effective. Now, some states, like the state of Washington, used it fairly draconian. I mean, if you build no new nursing homes, your Medicaid nursing home costs will come down, or at least not grow any. I don't think we ever considered using it that way in the state of Maryland as this sort of rationing tool. But it was a way of thinking about how you could control, kind of the system. You could play on the system to a certain degree, not have this open-ended problem that you were having at that time. Now, what we've seen since then is a very different way of paying providers. And so what we saw, like in the Medicare program, which is where most of my experiences was, you had these markets like Philadelphia and Miami, where when you ran straight fee-for-service, you ended up with them being very high cost per capita markets. When you went to something more, in that case, it was mostly the penetration of the HMOs, it had such a high payment rate under the fee-for-service. HMOs could come in, simply negotiate better with in-network kind of, the kind of designs we see, and they were able to beat those prices considerably. Philadelphia had at the time kind of an oversupply of cardiologists, and therefore to be on the in-network meant, and it drove down. So it was sort of a tool like CON. As your payment environment changes, I think we need to think about what we really think it can do. So you can see one of the things that causes me concern, and the number of issues that we've come across as the commission has taken up since I've been on, is that it's unfortunately been modified into a protection of the current players and the vested interest. And I think, as we've heard many times, much of the pushback is not, I will serve patients better, but wait a second, this is my turf. Why are you letting someone else potentially, whether it's hospice or any of the other ones that we talked about, why do I have to face competition? And that can't be good. So I guess I in aligning somewhat with the way you've taken this, I think we need to think about how we do CON, how we keep the good parts of it, the kind of health planning, being smart about things, being adaptive, but don't let it become a tool for kind of what we call in economics the guild mentality. You have a certain number of providers, they divvy up the market amongst themselves, and God help you if you try to come in. As Ben has pointed out to us, with our very unique plans and our sort of waivers, et cetera, there are probably enough barriers to, I'm an efficient provider in the district or Virginia or Pennsylvania. There's enough barriers to try and come into the Maryland market without us throwing up additional ones. And if we want to be both, as you say, we want to have it be as cost effective as possible, highest quality possible, best access possible, we need to make sure that the CON supports that, not is used by others as a tool to basically just stay fat and happy the way things are.
I'm a free market guy, kind of by nature, a little bit conservative. I own a nursing facility, so I've been around it now for, it starts to date me. I used to be the young guy, but now I'm not the young guy there. And I remember, just as Commissioner O'Grady said, with the CON process during especially the late 80s and early 90s was just, it was crazy competitive, at least in Western Maryland. And there would be pretty volatile battles over acquiring one or keeping somebody from locating in your area, et cetera. And a whole lot of it was tied to fee-for-service systems for both Medicare and Medicaid, both of which have disappeared in long-term care. Medicare went first over to a capitated system, and more recently, just within the last 2 years in Maryland, over to a reimbursement system driven by our case mix index instead of a fee-for-service, which kind of freed up the CON tie to competition, et cetera. So I also think, at least in our region of the state, where everybody thinks everybody's old, and we do have an older population than most of the state, that all of our nursing facilities are just full. And there's a couple reasons they're not. One is there's not as many elderly folks as people think live in our region. More importantly, though, there are competing factors such as home health, assisted living, adult daycare, et cetera, which models allow folks to stay closer to their homes longer, which is good. I don't mind competing because, our facility does very well. I have all the facilities in our area within a 15-minute ride to my place. And our occupancy is very high, whereas some folks have low occupancy. And that's based on competition and quality, which I think, and I've heard numerous commissioners say, and it's true, competition in theory, and typically as I've seen in practice, should drive quality, and it should lower cost. We hear all the debates right now regarding Obamacare, ACA, whatever you want to call it, and what healthcare costs are doing in our country. And it's a real challenge, I think, one that we haven't adequately even addressed, even with the advent of ACA or its impending replacement, or whatever side of the political spectrum you may be on, threatens to bankrupt our nation. And it's doing a very good job of it. It's one of the largest healthcare, basically one of the largest entitlement parts of our economy, and what we do with Medicare and Medicaid and such. So the further, from my perspective, the further we get away from the government managing who provides our care, and I'm not sure we're doing that in Congress, but that's another whole discussion. It's my belief that quality should go up and costs should go down. But that's my 2 cents. Thank you.
I guess 2 points that will be brief. So briefly, one is just, I don't know if there are other states that have done something innovative in the CON process that we would like to model it on. It's a very complex area. So if there's somebody else out there, it seems like a good thing if we study this in depth to know that. If there's something that we could pick up, and if there's a state that's revamped it. My second thought is the 2 other licensing systems I'm familiar with are insurance companies and public utilities. And they're the opposite ends of the spectrum. Public utilities, you really only want one set of water lines, right? You only want one set of electrical lines, and it tends to be very tightly regulated with obligations to serve, things like that. Insurance companies, nobody puts an upper cap on the number of insurance companies. You have to meet certain minimum standards of financial solvency, and you're in the market to compete, and you're not guaranteed anything. And I'm wondering if we look at what we're giving CONs for, are there some that should be more of an insurance company model where we're looking at, do we have reason to believe that the services will be well provided, and we don't care if there's already a lot of competition, and we're not going to consider that. We're going to take that out of the CON. And others where there's really large capital investments involved, and you would legitimately move it towards more of a traditional CON utility type of analysis, because you want to encourage people to make those investments, or where you want to encourage people. So it's just a thought looking forward is we have two different types of, you can see the different services. Someone would fall more in one, and you may be able to eliminate some pieces of that analysis if it's an insurance company type. We want to have as many people in this market that are quality providers as we can.
I'm going to keep it short. I basically agree with Mike O'Grady. I think what we need to do is we have to have a serious reconstruction of our regulatory system. I think, as we said, talking about this, we've talked about this for months. We've got to figure out how we can use our regulatory system to promote innovation and to promote productivity on the ground. And we can't really ultimately accomplish that unless we start to see healthcare as something that is really healthcare innovation, that is something that really comes from the ground up rather than the top down. And the problem that we all have today is basically, you know, most people in the healthcare sector of the economy are taking orders from people who are outside of their immediate jurisdiction of business. So, you know, doctors, hospitals, clinics, home health agencies, they've all got to deal with all of this stuff. Now, I am very, very certain that there are areas where, for example, a certificate of need really makes a lot of sense. Let me just mention a couple of things. I think we're dealing, like we just dealt with recently, a very large hospital system where there is a huge impact on the hospital system's development, either the hospital itself or a hospital program that's going to literally affect hundreds of thousands of people. There's a public interest, it seems to me, just as a matter of prudence. I mean, we're not talking about some kind of strict, you know, government, no government approach here. We're talking about exercising prudential judgment. There, in that area, it seems to me that the exercise of a certificate of need responsibility is very, very important. I think we ought to make that clear. I mean, because we're talking about, once again, we're talking about hundreds of thousands of people who would be affected by these kinds of decisions, whether it's a cardiac surgery program or the building of a new hospital and so on. The other area where CON clearly has a responsibility, I think where we have a responsibility over CON, is where there is any serious public investment. That is to say, where taxpayers' money is at stake in a project. Now, we had that actually with the Prince George's County matter, where if this institution did not make the right decision, the consequences would be disastrous for the taxpayer in the state of Maryland. I mean, it literally would have been disastrous. We did not do the right thing. We did, thank God. But the point is that clearly there is a need to exercise the kind of regulatory authority that we should exercise. Beyond that, I think we ought to start looking at opportunities. I think we ought to do a broader regulatory review of our responsibilities of the Commission to see what it is statutorily that we must do. In other words, we talked about this before. What is it that we must do as an institution? And then we ought to also look at what is it that we can do, where a regulatory initiative actually makes a great deal of sense, especially if that regulatory initiative can increase innovation in financing and delivery on the ground. The biggest need I think we have in healthcare is to promote basically disruptive innovation in the healthcare system, because that's where you get increased productivity and you increase the quality of services that are available. This happens in many areas of the economy almost every day of the week. it does not happen as rapidly or as effectively as it should in the healthcare sector of the economy. And there are a lot of examples of that. I'll mention one more thing before I stop. Commissioner O'Grady made reference to the concept of healthcare being a supply-driven phenomenon, a supply-driven sector of the economy. And that the classic article on this was Professor Kenneth Arrow, who basically wrote this magnificent article that had such great influence. The article that launched it, somebody said, an article that launched 1,000 PhD dissertations. Basically, what Professor Arrow was saying is that there's an imbalance, or there's an asymmetric relationship between the key drivers of health in the healthcare economy, doctors and hospitals and medical professionals, and those who are on the other side of the stethoscope. And that's correct. I mean, that was correct for a very long time. What I think is really remarkable about the time in which we live is how that idea has been watered down by common experience. And it is quite remarkable that if you look at what has happened over the past 10, 15, 20 years, is that regardless of philosophical conviction, people like Barack Obama and Paul Ryan both agree that patients should play a much stronger role in selecting what they think is best for them. They have different ways of going about it, but the interesting thing that is the common conviction that demand is going to have a greater impact. We've seen this move toward price transparency and quality, and this emphasis on laying bare the performance or the productivity of providers in the healthcare system. There's one fundamental reason for that, and that's the fact that we all believe that when people see raw data, they will actually act on it. Now, unfortunately, that data has been hard to collect and distribute in a consumer-friendly way in many areas. But that day is coming. I mean, that day is coming. There's a lot of things, there are a lot of complex sectors of the economy where the material in and of itself is complex, but modern social media, modern technology, modern information technology, and simple presentation is making a lot of these things in a lot of areas of the economy more accessible to ordinary people. I think that will happen here. So I think we ought to take all those elements into consideration when we start to reconsider our role and start to develop our own agenda over the next year. I think that we live in the most exciting time in health policy. This is a tremendous period. I mean, of course, people are angry about this, that, and the other thing. The debates in Congress right now and the state legislatures and all, we all know that. But the broad picture is that there's a greater emphasis on value. There's a greater emphasis, and it's a universal belief. It's not a partisan thing. There's a greater belief in value-based care. There's a greater belief in a good return on the dollar. And you know, the triple aim point that was mentioned earlier in this discussion today, the idea that we should pursue policies that achieve the triple aim, a good patient experience, lower cost, higher quality. All of that is broadly shared. But those things will not come to fruition unless we have real openness and innovation and flexibility in the regulatory system that governs this sector of the economy. I've already talked too much.
So thank you, Mr. Chair, for allowing us this time. First of all, you know, it's coming right on the heels of the previous discussion. We're all ripe for this kind of, you can see everybody's got something to say, and so I don't know if there's the timekeeper left, unfortunately. So I'm going to be briefer than my colleagues to my right, the left-handed ones. So I agree with everything they said. Okay, everything they said. So, but in all seriousness, I just really want to commend our chair again, not only for the work and this decision, but for this kind of discussion, I think, has characterized your chairmanship. So it's so easy. It's so easy for all of us to fall into the procedural things that we got to do to get through a commission meeting. And you've done that ably. But much more importantly is to encourage us to rise above and to look at some of the underlying principles or the overriding principles and really try to get better at what we do. So thank you for that over the years. And And now, okay, so now that I've used my time, no, I have a slightly different perspective, which is to say, and I was in the other room watching the proceedings with a couple of other colleagues, and this is not to cast aspersions on whoever said it. I don't remember who said it. Doesn't matter. But with some bit of glee, someone said, well, there's 600 cardiac surgery cases a year in Prince George's, and there's going to be another 600 in Anne Arundel, as if that was a good thing. Okay, that's not really a good thing. And if we wanted to contain costs, we would start knocking that down instead of trying to do a lot of kind of tinkering. Okay, so from a public health standpoint, when you said, and you raised great questions, is the CON focused on the right question, and could we do the right thing, or could we amend our processes a little better? We had to get through the question on the table today, for sure. But I don't think there's any clinical intervention clearer than cardiac surgery that's just so right for going upstream and looking at what all of the consultants and all of the lawyers are not spending their time on, which is to say, the lifestyle things that we know will keep people out of cardiac cath labs and ORs, the lifestyle things, access to primary care, access to medications, hypertension screening. It is not a mystery what lands in aggregate, what lands people in need of cardiac surgery. So what can CONs do, given that we're going to be innovative and we're going to do free market and we're going to be much more enlightened from a regulatory standpoint? What can we do to encourage the front end, the upstream action by the entities that come forward? I don't have an answer to that, but I think that really we need, for cost-cutting purposes as well as for population health improvement, we really need to dial that in to how we restructure CON. So right now, I'll give you an example, and it's not a good one, but we have, I think, in every CON standard, they've got to pass some litmus test for charity care, whether it's a hospital, nursing, there's got to be some minimum for charity care. Maybe that's good, maybe that's bad, but my point is that if there's a CON that comes to us from the cardiac chapter of the state health plan, should there be some requirements, some conditions to do population health work in some area that the community would need, some evidence-based area that could bring meaningful change in terms of the population's health as well as driving down the cost. So I don't think 600 in every county every year is a great number, and I think that we should kind of pay attention to how we can change that. Well, there's a lot of things that work, okay?
I wasn't going to say anything, but now I feel guilty because I was sitting in another room eating cookies. Potentially increasing the need for cardiac surgery. So I think that you were looking at me as you were making your comments because there's nobody in the room I think who's more critical about the cost of this process overall to healthcare than me. And as I think it was Commissioner Moffitt pointed out, this is a zero-sum game. When these hospitals add dollars to the process of applying for a CON, that dollars they're taken out of something else. The state limits how much revenue you can generate at the hospital, and you got to decide what you're going to use it on. And if they're using it on anything that involves people coming into this room, that's not accruing to the benefit of patients. And we have to remember that in everything that we do to create regulatory burden on the hospital. But I think it's important to understand that around the CON process, there are economic factors at play, and our attempt to create an economically balanced market is an important component of CON. But there are other clinical technical factors at play that are very important, and why I think that CON around things like cardiac surgery like this is very important. And even in states where there's no CON, they ought to consider CON around cardiac surgery. If you're doing 25 to 50 cases a year in heart surgery, you're probably not very good at it. And we don't want to expose patients to that kind of an environment. And you can't police it very well through any other mechanism. You try and police it through the tort system. We know that that's extremely flawed. If you try and police it through the licensing system, you have to get to a level of statistical significance and understanding who's doing well and who's not. If you create a balanced field where people have to get to a certain number of cases before they're entitled to begin the process, you do a good job of ensuring that there's at least an opportunity to achieve quality.
the same side of that discussion, I don't know how you get the same quality bang for your buck out of a process that asks the hospital to come in and justify adding 500 square feet to an operating room. Or a hospital that is owned by an insurer who wants to come in and expand an ambulatory surgery center with its own money. I don't know where we fit into that process and create the same type of value. And I think that as we think about reforming this process, we got to think about how do we limit it to quality, because when we're not doing that, we're asking to put money into things that aren't healthcare, that aren't taking care of patients. I think one of the best examples of things. Now, the other question is, the degree to which the supply creates the need, and that if you oversupply, you create an overneed. And there's some argument for that. But I think, as Chairman Sabatini from HSCRC next door once said famously, that it's very difficult to understand how that supply side argument applies to OB services. That unless the obstetricians are doing something with the patients that's sort of not appropriate, yeah, it's very difficult to understand how that supply argument spreads across the number of services that we're talking about. I would argue that nursing homes fall into that category too. I don't think people are putting their family members in nursing homes because nursing homes exist. I could be wrong, but whatever. And finally, I think with regard to innovation, I think we have to promote innovation. We want to create models where people are inclined to innovate, because I agree completely that doing 600 cardiac surgical procedures a year within a population is not the long-term solution. The long-term solution is to eliminate the need for that. And there are lots of ways that we can be doing that. But again, when hospitals and health systems put their bandwidth, their available bandwidth, into this process, they're not putting it into something else. And that's the zero-sum game that we have to continue to remember every time we create a regulatory burden on the healthcare sector. Living at that healthcare sector at a ground floor level, I feel that regulatory burden as a care provider every single day. We spend more time documenting what we do for the purposes of billing than we do doing it. And that doesn't accrue to the benefit of patients. And that's what we have to remember as we go forward.
So many comments have been made that I agree with. Some I take exception to a bit, because as we know, things are not one size fits all. I mean, that's just the reality. So in terms of understanding what goes on in the market, talking about provider-induced demand, it still happens in some areas. There's no question. I was going to make a joke, but I won't. Anyway, so we need to look at what category of service you're talking about. I mean, just, Dartmouth Atlas. I mean, there's clearly some areas where it is a serious consideration. The demand that comes from the consumer or the patient, I mean, as many of you know, I mean, that is where my heart always lands. And the importance of focusing on quality and making sure it's transparent, but making sure it's transparent in a way that it's understandable to people and that it appears when and where they're making decisions. And it's an issue that we've talked about many times, that the Commission could be taking the incredible work that's done by staff and others and to parse it out to make sure that the right, correct, most influential pieces of that information or that research appears at the very moment when somebody's making a decision about open enrollment or about choosing maternity services or whatever it might be. I mean, it's not rocket science, and it is being done very well in certain areas, and we could adopt those things as well. So I think there are some things that, really setting out the principles in the certificate of need process around, not taking a one-size-fits-all approach, really looking at where it's most appropriate and where it's unnecessary, where we want to encourage the innovation, let's take our hands off of it and just let it go, right? Let it happen. But there are some areas we need to be involved in. How do we put the focus on quality? How do we do it in a way that people who are making the decisions actually have the information, it's relevant to them, they understand why it's relevant. And then finally, the third thing. So one is the provider-induced demand. Second is the transparency and really making the effort to put the information where it's useful. And then the third is, I think many times we've talked about, and I'll say it. For me, I have worked in many different states, and I have never been in a state that is more hospital-driven than Maryland in terms of the healthcare system. And we've got to think beyond the walls of the hospital, and not just in the silos of the different services, but really looking at coordination and connection. And one of my roles in this life is I am part-time executive director of the Patient's View Institute, where we collect stories from patients all across the country to see what the themes are. We basically shut up and listen. And we don't say, here, take our survey. We say, tell us what's important to you. What is your experience like? And we have thousands of stories from all different perspectives. And one of the things that comes out loud and clear is the need for coordination and connection. Because from the patient's perspective, it all should be connected. And we need to think of the system that way too if we're trying to create incentives that work for consumers. So thinking beyond the walls of the hospital to the ambulatory sensitive services, that Fran has touched on as far as population health. So investment to improve health, coordination in the community health, not only the needs assessments that are done by the hospitals, but also the improvement plans. There's just so many opportunities in this state to really drive the coordination that needs to happen, not only among hospitals and others that serve the same area, but across the various services.
Hospital assessments, not to interrupt you, Diane, but those are requirements of the ACA that every hospital do a community health assessment every 3 years and put their community benefit, or at least some of their community benefit expenditures towards an implementation strategy, blah, 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 blah. It's in the ACA, and the future of the ACA may be, it is in jeopardy, and whether or not there's a federal substitute for that, I think it's something for us to take. We're going to be watching to monitor that, but these community needs assessments right now are the entree, I think, for hospitals to do just what you're describing, to really get outside their walls, in addition to what's happening next door. But if that goes away on a federal level, it might be something to pay attention to.
It's part of it's associated with IRS requirements for 501c3 hospitals, the community health needs assessments, and then the improvement plans, and then coordination with the public health improvement plans, which are done separately. Don't talk about duplication of effort and time and energy spent doing this planning. So there are things that we could do in a very innovative way in Maryland to really pull that focus beyond the walls of the hospital that connects across those silos, that allows for that innovation.
I just have a couple of comments. Just looking at this process, there are some things that struck me from not just today, but previous today as well. The first and foremost, which I think made me the most sensitive to the process, is the focus on saving profits over saving people. That really disturbed me. Also, the cost to navigate the process, that it inhibits smaller, innovative thinking when you have large entities in the attack mode. I think it's prohibitive. I love the idea of encouraging positive health outcomes. But I think we also need to encourage people for the things. Another thing that has been talked about a lot in here too is the infection rate. What are you doing to curb that? We talk about it, but there's nothing that we actually do about it, and that would be one way of doing solution to it. The pluses from what I saw from today is I like the input from real people from the community. I think that is a valuable point of view that sometimes gets lost. And the professionalism of the reviewer, but also of the staff, drilling down to validate all the information. Just because somebody says, well, this is what this number is, we can't just accept that. It has to be drilled down. And I think, unfortunately, as the story gets beat and goes out, that'll get lost. But it's a very important part of it, that the role that this board plays is that to validate that it's real. Okay, thank you.
I appreciate people's input. I think we'll have to figure out where we can channel some of this energy, and we can talk about that offline and then maybe come back. What I would just
Well, I did.
did you want to?
Yeah, I wanted to say,
Okay.
I think so. The job that the commissioners have done on these really controversial decisions is impressive, and I don't think the staff can thank you all enough for these. This is, in some cases, really almost like light work that we see people doing on a voluntary basis, and when we sometimes feel a bit of anger when we see some of the challenges that the reviewers have to face, and they do it in good grace. But what I really want to say today is that you did have one accomplishment, which is you made the Maryland market for cardiac. You can't. The Maryland market for cardiac surgery services became a bit more open. One operator, a community hospital, is now approved to open a cardiac surgery center, which I think is something noteworthy here. I think that one of the things that we think about when we think about streamlining, administrative streamlining, we can focus on, and we have actually done a fair bit of this, is streamlining, making the process simpler for the stakeholders, those that are in the market today. What is really much more challenging is the ability to promote innovation through administrative simplification. I don't want to just say CON, but just through regulatory reform generally, and also creating more competition. I think we can make it simpler for people, and I think that there are intentions that through the merger of the two commissions, we would make it simpler for the entities that are operating in the Maryland market. But I think that should not be simply the test that we try to meet, but we should try to also provide additional opportunities for innovation and for and what go hand-in-hand competition. And those are, I think, bigger challenges, because many of those that would cheer for streamlining are not going to be so enthusiastic if that streamlining opens the marketplace. I'll leave you, and I've asked the staff this a couple times. If Apple Computer came here to get a CON, they would have a hard time, an innovative organization, because the structures that we put in place in many cases are very, very difficult for new entrants. And at a smaller level, we saw that with Recovery Centers of America. We don't really know, are they a tremendous new entrant? They are okay. They won't perform well. But what we do know, it was very hard for them. And I think that our processes can't be as much of a barrier to entry as they seem to present today.
Part of the way I view this is that this is a tool that was developed where oversupply was problematic. I think we have a nice consensus on what we want to protect. It is kind of triple aim, or whatever you want to call it. So it's quality, it's cost, and it's access. And so in my mind, when you talk about why are you making these people who just want to expand their surgical, their operating room by 5, that doesn't meet my test of an oversupply in this area is going to hurt any of our 3 core sort of desires. If you say to me that we're not going to have enough hospice in the state, that's getting more. So I guess, when you think about this notion of it's not one size fits all, there's some people we probably do want to see a lot of evidence, a lot of proof of concept. We want to see a lot, and we want to have some way of letting them know that, versus other people that you say, fill out the form, we'll talk about it, and you're good to go. Or don't even bother coming to us, however you want to think about that. But that's sort of my decision rule. Is oversupply going to hurt quality? Is it going to hurt cost? Is it going to hurt access? And if it doesn't, it just drops, I don't know how much time, effort, et cetera, hoops we want to make them jump through. If it's not, because that's what our basic tool is about.
My belief is that staff has been thinking about this a great deal, and that in fact it would be pretty straightforward for this group to come to a reasonable consensus about what the real opportunities are and to prioritize that. I think the challenge that we face is actually that there are a number of stakeholders in the system that have a vested interest in keeping the status quo. And so that, in fact, I think we face a different situation. It's not that the commission who's implementing the regulation sort of has views on how that could be changed. It would be that the stakeholders say, hey, we like the way the structure is, and we're okay with some of the costs if it's doing that. And so I think that dynamic, as we're going to problem solve, we need to incorporate that into our problem solving.
So I agree that dynamic is loud and clear out there. But our job is to come up with our best recommendation. There are some things that are going to require legislative change. It's up to the legislature to accept them or to not accept them. So we shouldn't be held back in what we recommend based on what we think the legislature will or will not do. I think that at some level, it's our job to make the argument clear and concise enough that the legislature will understand it.
Yeah, I just want to add to that and say that the Maryland Healthcare Commission is a public service commission. Our interest is by definition the public interest. Private interest, protecting them, defending them, insulating them from competition, making sure that they are able to maintain their bottom line, that is not our job. In fact, it is exactly the opposite of our job. Our job is to serve the general welfare of the people of this state. And, with regard to the state legislature, it may very well mean that we have to have, I don't mean a confrontation, but I mean a very strong presentation to them about how we see our vision going into the future, and make it very clear that we do consider our fundamental responsibilities to serve a public, not a private interest. Political authority in a republic exists precisely because the political authority is held as a public trust to serve public interest, never private interest. As the Romans said, there is a fundamental difference between the res publica, which is the public affairs, and the res privata, over which the state should absolutely have no control. And we have to make these arguments. They're very basic arguments, but they're arguments that are fundamental to the kind of society in which the founding fathers gave us.
Well, on that note, we've had a great discussion. And then now Eileen is in the challenge of presenting us with the update of the state health plan regulations for general surgical services with that context, and providing both what the current regs are and how you're going to get proposed changes and feedback from the work group meeting. So, please, want to talk about that?
What are we going to do with all of this?
Yeah.
This is a great discussion. Can we summarize what we're going to do with the information?
Well, I'll put something out there. I mean, I think what we should, given the conversation that was brought up on the legislative agenda, I think that there is a discussion on the table around this. I do believe we should have a work group within the commission to go in more in depth and use that process and then bring it back to the commission. So that we've used the work group in the past structure to just go deeper into the issues. And this certainly, what I know from the feedback here is that it's an issue that people are passionate about. There's a reasonable, emerging consensus about some of the principles in here, and a dissatisfaction with the status quo the way it is today. So that's what I would propose as a process. No, I think it's
but that's important. That there is a piece of legislation sitting out there to potentially merge the two commissions, and part of that the mission, or if you will, the charge was to revise the CON process and just this direction potentially. It's who knows what's going to happen with legislation. I'm not here to predict that, but there will likely be either that occurring or something else that directs us to do the same thing from the legislature. So I think I think there's a pretty good chance that by the end of the session, we're gonna have a pretty clear idea of what we do next with regard to the question.
Yeah, I think that Commissioner Pollack probably is fairly accurate. That I think that we're likely to get minimally some a request from the legislature to undertake this, which I think is better than doing it simply by ourselves. And we'll have to wait a couple weeks, but I'm fairly sure that there will be some framework. I think the question will be, how will it actually be organized? Will it be the commission would be a participant, or would the commission be the organizer? And I think there are advantages to both scenarios that we probably want to talk further about if we're given an opportunity to comment on it.
Perfect. Eileen, back to you.
Okay. Thanks so much. So I do want to give you an overview of the current regulations and kind of explain some of the changes and the feedback that we've gotten, and then of course get your feedback on these issues. So we were asked to develop regulations for an exemption process for providers of ambulatory surgical services to add a second operating room. Right now in Maryland, we have a lot of these 1 OR facilities that can be established through getting a determination of coverage. And so that's seen as being a little bit inefficient. And we do have the authority to have an exemption process so that one of those could add a second operating room, but it's something that we haven't actually implemented previously. And then another reason that we're updating this chapter is that we need to account for potential changes to the regulations for freestanding medical facilities, and so which may have surgical capacity, and so we wanted to incorporate that also into the state health plan. So we did primarily focus on the exemption process, and that's what most of these slides will focus on. There were not a lot of changes that we made in terms of the CON regulations that are in place or other aspects of the chapter. So on this next slide, I have the authority for establishing this exemption process. Essentially, the office of one or more healthcare providers or group practice performing ambulatory surgical services with 2 operating rooms may be exempt from CON requirements if the commission, in its sole discretion, determines that a second operating room is necessary to promote the efficiency, safety, and quality of the surgical services offered, and the office meets the criteria for exemption from CON review as an ambulatory surgical facility set forth in the State Health Plan under COMAR 102411. And then on the next slide, I also included the statute that we believe allows MHCC to establish an exemption process for a hospital that's converting to a freestanding medical facility and wants to create an ambulatory surgical facility with 2 operating rooms on its campus. Essentially, the surgical capacity to the state's health system in that circumstance, as long as it's not increased, then it's not subject to CON, we believe. I think, as I mentioned, CON approval is required to establish a facility with 2 or more operating rooms. And so the idea of this exemption process is to have a quicker process, not as many barriers as the CON process. And the alternative, as I mentioned right now, is just to get what's called a determination of coverage and to have 1 sterile operating room or only procedure rooms as part of that ambulatory surgery center. So having that set up for our regulations has resulted in a lot of these ambulatory surgery centers that just have 1 sterile operating room or procedure rooms or some combination of that. And we think that making this change with an exemption process could increase the cost effectiveness of providing surgical services. And so basically we talked about the circumstances under which someone could get one of these exemptions. Essentially, an existing POSC, which is one that has just 1 operating room, could get this if it's operated for at least 1 year. And then also 2 existing POSCs that operate no more than 1 operating room each, and that if both operated for at least a year, could combine to create something. And then also a general hospital that's seeking an exemption from CON to convert to an FMS that wants to create surgical capacity on the campus would have an opportunity to go through the exemption process. And so for that process, the general standards that apply to CO interviews would also apply to this process. And those general standards include information regarding charges, information regarding procedure volume, charity care, quality of care, and transfer agreements. So I'm just going to go over some of those in the next few slides. In terms of charges, we did have on our work group the director for the Consumer Protection Division of the Maryland Attorney General's office, and she provided feedback and expressed concerns that consumers were being surprised by bills from providers about surgical services, and she was interested in having us try to address that in some way. She said there has really been an increase in the complaints that her division has seen. And so we have proposed modifying the current standard to specifically note that complaints against a POS, an ambulatory surgical facility, or hospital regarding their failure to disclose charge information will be a factor in determining compliance with the standard. And so we can't hold a POS accountable if an affiliated provider, like the anesthesiologist, failed to disclose the charges, but at least we can, for the facility fees, have something where we try to hold them accountable. And so we thought that revising the standard would promote that goal. And the work group is supportive of this approach. In addition to revising that standard as it applies to certificates of need and exemption requests, we've proposed revising information requested for determinations of coverage to make it clear that the POS are required to provide estimates of out-of-pocket charges for patients. The director for the Consumer Protection Division of the Maryland Attorney General suggested that the regulations for the Office of Healthcare Quality be updated. Those are ones that actually speak directly to the obligation to provide information on the out-of-pocket charges. We thought those could be strengthened, but that is outside our control, so we're just trying to do what we can within our own regulations.
In terms of when the consumer protection and the idea of patients being sort of getting that sticker shock on the cost, did she give you an idea of kind of where that was coming from? Was it a particular group of patients? I guess what I'm wondering is, as we move more and more to an outpatient setting, are we seeing, is this Medicare people who used to be covered under a DRG payment who are now being charged? It's, you know, we had this problem with observational stays, that all of a sudden their out-of-pocket expenses were significantly higher than if they had just been admitted. Did she give you any feel for, is this just across the board consumers? Is it a particular group like seniors?
Well, she mentioned that what happens is there are facilities that are out of network, and sometimes they say, like, well, even though we're out of network, we're just going to charge you this amount, what you would get in network. And that's not something they can do. I mean, she mentioned there was like a legal case where there was an issue with telling patients the bills were one thing, and then the insurance company is being told something different, and the patient has this out of network benefit, and so they get a lot more money from the patient than they should, than they should be.
I might be able to help you with this a little bit. There are, and I don't know how frequent it is, but you see it frequently in complaints where you have an in-network doctor who goes and gets, I'm going to give you a service, I'm going to refer you to my ASC. The ASC is out of network. The patient calls the insurance companies, they talk about the service by the doctor, the insurance company lifts it up. If the patient doesn't know to talk about the ASC, then they may be like, yes, that doctor's in network, that's what your charges are. You go, you get it done, and the patient gets a bill from the ASC for some amount of money that they have no idea what's going on. I just talked to my insurance company. That at least is one model of the complaint that we've seen.
Now, that would include both not the negotiated rate and the balance bill?
In that case, the ASC is completely out of network, so whatever they want.
They can charge whatever they want.
Right. Okay.
I mean, it sounded like, as you expect, there is a little bit of range. Like sometimes it is a misunderstanding, but sometimes they really didn't get accurate information or the information at all. So it's something that's a concern.
Yeah, I think that needs to be commented upon. So there are a couple of pieces of this. So in having the direct experience on the board of one ASC, no direct ownership interest, but direct experience with it, we've been unable to get certain insurers in the state to participate in the ASCs, and the reason that we're given very clear that the insurers are already paying through the GBR for the services to be provided at the hospital. And if we pull the services out of the hospitals and move them to the ASC, that total cost, the hospital doesn't change because the GBR doesn't change as a result unless you break through a threshold window. And as a result, it's not our interest, even though the cost per case is lower at the ASC. So the only way to get the cases out there is to do it out of network. We've done it in a way that keeps the burden on the patient the same as it would be if they had been in network. But there's reluctance on the part of the insurers in the state to break through this HSCRC created barrier through the GBR and facilitate the growth of these lower cost outpatient facilities, because it represents killing the goose that's laying the golden eggs right now.
Right, there was a work group member that did bring up
right.
that.
So, but it can accrue to the detriment of the patients, and that's what we do have to protect against. The other side is, I disagree with the statement that we can't control the anesthesia providers. You can. The anesthesia providers don't walk in off the street and decide that they're going to start delivering services in an ASC. The ASC actually hires them. So I think if the ASC is going to hire them and they're going to be out of network, they have to disclose that to the patients in advance, that they're doing so out of network, and that the cost may be higher as a result.
Right, there was an interest in strengthening the regulations to make it clear of the obligations for a center to provide that sort of information and explain how to contact a third party that's going to be involved too. Yes, so there's something else I wanted to say. But that's it. I can't remember right now. Okay.
Can I ask just one more question then on the complaints? When they're factoring complaints in, it seems like a situation with an ASC is discussed as network, and it's very upfront about what it's doing. Even if they get complaints, it's different from an ASC. That's more of what I was talking about. We're not just going to weigh complaints, are we? I mean, there are complaints.
No, I mean, I think we need to know the nature of the complaints. Like, we would want to understand, is it something that we can fault a facility for, or is it not something that they're really responsible for?
If the ASC's been upfront about what's going on, and this person just doesn't like the bill that they're upfront about, I think that's.
I'm just trying to point out that we don't have a pure free market environment in the state, and
right.
that it's a little bit disrupted by certain things that aren't true anywhere else in the United States. And I use the word "else" loosely.
Right. There was one particular case that the director for the consumer division mentioned, which was an endoscopy that the patient was billed like $29,000 or something. It was just very absurd in terms of the bill charges. So it's concerning for them, and we've tried to address that to some extent. Another standard that we've added, this is something new, information regarding procedure volume. This wasn't in our standards previously. We wanted to add the standard because we concluded that procedure volume is relevant to an individual's decision on where to have surgery because of that relationship between volume and quality. And we received feedback following the work group meetings that greater reporting of volume of information should be required. And so we're trying to address that issue that had been raised, but it was not something that the work group specifically considered or discussed, since this came up after their work had concluded. And so the standard would require that upon inquiry, ambulatory surgical facilities, POSCs, and hospitals provide information on the volume for specific surgical procedures for the most recent 12 months available, updated on at least a quarterly basis. The existing POSCs cannot be required to provide this information. However, for future POSCs, the request for a determination of coverage would include a statement attesting that the center or facility shall provide volume information for specific surgical procedures for the most recent 12 months available, updated on at least a quarterly basis. Next, the charity care standard. This is a standard that we revised in our last update to the State Health Plan chapter, which was about 5 years ago, to promote greater provision of charity care for ambulatory surgical facilities and POSCs that want to become ambulatory surgical facilities. There were no proposed changes to that standard, and the consensus of the work group was that we should maintain the current standard. For the quality of care standard, under the current regulations, an existing ambulatory surgical facility needs to document that it's licensed in good standing,
by DHMH in compliance with conditions of participation of Medicare and Medicaid programs, and it has to be accredited by one of several agencies. An applicant proposing that an ambulatory surgical facility must demonstrate that it will meet those standards, and a hospital needs to be accredited by the Joint Commission. In addition to that, we've proposed another criterion for that standard. An applicant needs to provide information on how its existing POSC or ambulatory surgical facility performs on quality measures adopted by CMS. So there have been some performance measures adopted. It is voluntary, but there is a financial penalty, I would say, if you're not participating. And so there is very high participation. I checked on that. And so we think that there's high participation and it should be readily available, and that it would be useful in terms of getting a better picture of the quality of these programs. And so the work group did discuss that proposed change, and they agreed with taking that approach.
Correct. You know, if those standards, the CMS standards include infection rates for ambulatory surgery sites.
Infection rates?
Or healthcare acquired infections, or some kind of infection metric.
Like
I
the
think,
CDC measures.
Right. There's a developing body of, I'm going to say, concern about hospital infection rates are one thing, but ambulatory infection rates are such that the patients instantly disperse, and then to go back and do an investigation post-procedure gets even more complicated because of the geographic and clinician so.
I don't recall right now. Like, it seems like they are expanding the list, like they have plans to expand it. I know that they have like never events on there and certain other measures, but that one I'm actually not sure about. I think probably not.
Might be something that that you might want to look into. I think it's a developing area of concern as there's more and more procedures that are migrating.
Okay.
So related to this, and tying back to the conversation we just had about the consumer complaints, quality of care, if somebody is getting services within a hospital, at least there's HCAHPS, there's something that looks at patient experience. And frankly, just because something has been communicated by a facility or provider, it doesn't mean it's been understood by the patient or the consumer. So increasingly, an aspect of quality is listening to the patient to see what they thought about the quality. Was that considered, or is there some room to make sure we don't lose those patients as they don't have a service in a hospital, they move to a setting, and then we're not asking what their experience was?
Well, I think part of the idea was that we would stick with something that's already out there, that there's high participation on it. And so, like, if there is something that already exists, then I think that's something we could consider. But I don't remember that coming up specifically. We kind of focused on the CMS quality measures.
It would be great to look, and I'm happy to help as well, just to see what might be out there, because we don't want to lose the patient experience in this mix. And if that migration out away from a hospital setting means they're migrating to a setting where there isn't some effort to understand the patient's experience in this, we need to figure out how to address that.
Okay. Are there other comments?
In other words, I was thinking with the same standard for two, we can not apply it if you want to add a third operating room, or is that written?
No, it's two. I think back on one of the slides, it specifically refers to adding a second operating room.
So if that's it, it's for adding a third, we have to get.
It would be a CON, yes. That is something we talked about in terms of, is there this limit of 2 operating rooms really, or could someone just keep going one by one, adding an operating room and avoid CON altogether?
Yeah, my question would be, if it works for a second one, I'm not sure why we would do it differently about adding a third. But if it's written in the statute, you really have to.
It's written. Well, no, this is your suggestion of how to lighten up on the CON process, right? Let them have a second one without having to go through the full bells and whistles. But if you want to go to a third, but you're right, it's going to create a little bit of a cliff. You'll see a lot of facilities with 2. I mean, isn't that what you're saying now? We have a lot of facilities with one.
Right.
One, and now it'll go to a lot of facilities with 2.
Well,
but at some
I'm not
point,
sure.
you have to fill out a CON.
yes, I mean, I think we'd be more concerned, you could say, in terms of competing with a hospital and the impact there. But it does specifically refer to a second operating room. It's on slide 4, where I have the statute quoted. So I think that's how we interpret it, that it literally meant a second operating room, not a third or a fourth.
Why don't you keep going through to need, because that starts to get into the core issue of the right.
Okay. I could just, so this slide, I just put the standards for each of them to show that it's a shorter list for exemption requests, that there is overlap. So the needs standard for both a CON to establish an ambulatory surgical QRRs and an exemption request would be very similar. Basically, the proposed operating rooms need to be utilized at or above optimal capacity within 3 years of the beginning of establishing them, either new capacity or replacement capacity. And the optimal capacity assumptions have not changed.
Talk about this optimal capacity issue, because I think optimal capacity is defined as 80%. Is that what we use?
Of full capacity, yes.
Yeah, and 80%, when you're thinking about a pure ambulatory surgical facility that's cooking along, 80% sounds wonderful. But when you look at how operating ASCs are utilized nationally, 80% is not a good number. It's a bad number for people to want to be in. The most expensive piece in the operating room is the staff, not the facility, not the capital facility. And the staff aren't utilized well when you're at 80% capacity because you can't flip rooms very well. So when you, by flipping rooms, you bring a patient into a room, you begin the anesthesia process, you get everything set up, and that process takes a period of time. And during that period of time, the surgeon can be standing around doing nothing, or he can be completing the last case. And if you have overlap like that, you necessarily have dead time in the middle, and that dead time doesn't allow you to get to 80% capacity when you're using 2 rooms. But the cost of the personnel is greater than the cost of the facility, so it's still cost effective to run it with less than 80% capacity. That's issue number 1. Issue number 2 around the 80% capacity is that it doesn't allow you to take on emergency cases. And you say, we never take on emergency cases in an ASC, right? Well, that's in the old model. In the model where we have an ASC attached to a freestanding medical facility, and that's how we're licensing it, we do have an emergency department, and we may want to be able to take cases from there into the ASC. And if we're running the operating rooms at 80% capacity, we're not going to be able to do that. So or somebody's going to get hurt in that process. So I would argue that the 80% number, that optimal capacity number, is not something we should be paying attention to in the CON process. That's what the market should be paying attention to. And that's not where we get in terms of quality, because if they've got capital facility laying fallow in an unregulated environment, who cares? That's the responsibility of the investor, not the and the market, not the responsibility of the regulatory agency.
I would say that we do allow for turnaround time, like that time between cases. We don't.
That's not turnaround time, what I described. That's lay fallow time in the middle, so that you can have one surgeon assigned to 2 rooms at the same time.
Right.
And you may have 2 hours in the middle where that room is going empty between cases, if the cases are on the long side, and that's okay if you're running the facility. You decide financially whether that works or not, and that doesn't drive up the cost of healthcare unnecessarily, because the cost is determined by other factors. It allows you to decide how to build efficiency. I don't think that we ought to be deciding what that percentage is in terms of utilization that way. We need the flexibility to allow the market to decide that.
So how would you propose that we decide that someone is fully utilizing the operating rooms? Like this applies to both hospitals, which are rate regulated, and
rate regulated operating rooms in a hospital are different. They're not. The market forces are completely disrupted there. This is different. This is the non-rate regulated ambulatory surgery center.
We should have optimal capacity standards for hospital ORs, but we should have a different approach for ones that are in the private sector.
Potentially, the private sector, public sector. I'm not sure what that means in that.
Well, unrate regulated
versus unregulated.
We'll stick to that.
But yeah, I think if the state is going to pay for all the revenue that goes in, the state ought to have a lot more say. But that if the surgeons own the facility and the surgeons own their own costs, they ought to decide where the dollars where the expense should lie. And the expense of the surgeon standing around doing nothing for an hour, not while there's turnover, but while there's patient in the room getting prepared. Because the patient comes in the room, it's a long time before incision occurs. That decision ought to be with the owners of the facility, not with the state.
So just a quick follow-on to that, a way to look at this might be to think of the outcome and what outcomes matter. And that may be a level of minutia, and I'm using that word in intentionally almost a pejorative way, and I apologize for that, but that level of detail may be unnecessary. So what is the outcome? The outcome is around efficiency. The outcome is around inefficiency in terms of cost, perhaps, or patient safety. You know, thinking about things like that, and that becomes, to me, a better way to evaluate, as opposed to getting into, you know, a level of detail.
Paul, do you have any perspectives on this?
Come on up.
And then while you're coming up,
Sure. I just want to go to Andy's point here. I mean, part of the notion of getting into this was because we saw things under, you know, certainly in Medicare, we saw kind of this proliferation of MRIs and things like that, where they were not being used very much at all, and it was sort of, you know, like helicopters. It was cool for your facility to have one, whether you used it or not. And so given the payment operation there, it was the taxpayer who was at financial risk. If the point is that we're now in an environment where it is not the taxpayer at risk, it is whoever holds equity in this freestanding facility, and that is kind of a closed loop and quite clear. Yeah, the whole justification for why the government would say what utilization a particular facility should be does tend to, you know, the whole justification drops away. And I wouldn't lose any sleep over it as a regulator. That's not, you know, if they lose money, they lose money. Unless you tell me there's something about the grand plan in Maryland that says that if these guys run into financial trouble and it's just not making the money they had hoped it had and they have to close the door, somehow the taxpayer is on the hook for it. Or there's a manipulation of a payment rate.
Yeah, I was going to say, or it gets built into rate, which is what regulated space is, where if you build too many, everybody pays because it winds up in the hospital rate. But that's not this situation.
Or it hurts patients because they end up holding the bag in terms of the billing, and or from a safety standpoint. I'm just thinking about those factors. It's not just the investors. The impact on patients, I think, really needs to be factored into this as well.
Yeah, our regulatory approach historically has been one where we really don't care much about impact in the non-rate regulated outpatient surgical sector. In fact, you know, our plan very specifically since 2012 has said we care about impact that development of outpatient surgical centers may have on hospitals because they are rate regulated and because we don't want to leave, you know, stranded capital assets at the hospital. But essentially when we get someone coming in and saying, oh my gosh, you can't let this outpatient surgical center be developed over here because he's going to take my doctors and that'll just, you know, put me out of business, we kind of say, you know, we don't really care. So, and in the work group setting, I mean, you know, we had a lot of people who kind of said, well, that isn't right. You know, why don't you care about impact on us? And that's what we said. We said, well, you know, we have a very loosely regulated system now. Most of the players in the system never came through this commission. They're operating these one operating room facilities. They're strictly market price. So, you know, have at it. But we do pay attention to impact when, you know, the orthopedic group wants to move across the street and build their own facility, and that's really going to, you know, drain a lot of the outpatient orthopedic work out of the hospital, and the hospital just built expensive operating rooms.
That's the actual problem with the GBR. Okay, so when you can build an ambulatory surgery facility and do that procedure at a lower cost per case than you can in the regulated facility, then the patient wins. Right? they have a copay, and that's what you're preventing by establishing barriers to doing this stuff. We have to create flexibility to innovate and to move cases from a higher cost setting to a lower cost setting. And when you, again, it's on the ground floor level, that's not what's happened in this state. We're doing more arthroscopies and ACLs on an inpatient basis here than anywhere else in the country. We're not moving from inpatient total joints to ambulatory surgery center total joints at the same rate that they are in other states. And the flexibility around the ASCs is one of the reasons. It's a combination of the ability to negotiate with the payers because they don't want to kill the GBR, and the inability to build the ASCs because they would hurt the hospitals. You've got to allow competition in certain areas in ways that accrue to the benefit of the patients and to access to care at lower cost. And again, we've got to preserve quality in that process. There's no reason that the same quality standards shouldn't apply and the same patient satisfaction standards. But if you look around the country, the numbers are the opposite. The quality's better at the ASCs in those markets, and the patient satisfaction scores are higher. So that's what we need to. That's why we need to promote that.
I totally understand that economic argument, but on the other side, historically, there has been an argument that it's a good thing that we pay hospitals more for those outpatient orthopedic surgery procedures.
You got to come up with that argument because it's not holding any water based on data.
Well, it's because the hospitals are on the hook to take care of patients that outpatient center across the street is not going to take care of, and they don't have insurance, or they are Medicaid patients and they get, slightly less, than they get for insured patients or Medicare patients. In other words, if all of a certain class of patients who are the less lucrative sector of the market are all going to continue to go to the hospital, none of them are going to cross the street with those orthopedic surgeons, are they?
Yeah, that's not true. In other states, it's not true here either.
Historically, it has been.
Well, maybe historic. I would say that's simply not true. That in Medicaid models where there's a reasonable Medicaid reimbursement, that simply doesn't happen. In Medicaid models where the reimbursement falls well below the cost of delivery of care, the variable cost of delivery of care, which is pretty marginal in an ASC, then it happens. But so
if you look at outpatient surgery in the hospital setting in Maryland, the percentage of patients who are Medicaid is far, far higher than it is in outpatient centers.
Because those patients don't have the ability to get to where the ambulatory surgery centers are, because we build the hospitals around where the Medicaid population is and not out in the suburbs. And you won't allow people to build ambulatory surgery centers right there.
I'm not criticizing the kind of dilemma that you're talking about.
It's an absent-free market, and there shouldn't be an absent-free market here, as long as you preserve measures of quality and patient satisfaction.
And I'm not criticizing those orthopedic surgeons who built across the street from the hospital, because they serve Medicaid patients. They just don't serve them in the facility they own. They serve them in the hospital. And I understand why they do that. And it's not that they're bad people. It's like, well, the hospital is going to be okay when we serve uninsured patients in the hospital. I do surgery on people, and I'm giving up my professional fee when I do surgery on them in the hospital because that person has no insurance. But they don't bring that person across the street into their own facility, because then they not only they don't get their professional fee, which they don't get in the hospital either, but the facility doesn't get any facility fee reimbursement either, and they own that facility. So they're
making sense to me, because this is the Medicaid managed care organization argument that you should be taking to them. I mean, if they're going to pay hospital rate regulated rates for the procedure to be done in the hospital, why won't they pay anything close to that in the ASC, and the ASC will make a ton of money? I mean, we're talking about rates that are half of what they are in the hospital. So that your argument's in the wrong direction. We ought to be looking at the MAMCOs and saying, hey, why aren't you guys negotiating with the ASCs for rates that'll make up for the difference on the professional side, because you'll still save a ton of money compared to the hospital. And the argument is because we're going to kill the goose that's laying the golden egg. It's going to be money in addition to what we're paying to the GBR. You've this is what happens when you take competition out of the marketplace.
In response to the discussion that was going on when somebody asked me to come up here. Yeah, I read, the literature, or at least some of it, about how do you schedule surgery, how do you create the most efficient model for doing outpatient surgery with different
kind of approaches to having doctors moving from one room to another and doing surgery. And I would agree that a lot of those are persuasive in terms of, obviously saying, well, it doesn't make sense necessarily to have some sort of rigid, capacity assumptions that you apply, and looking at what the best business model is. In our simple way, that's kind of the way we have historically looked at approving expansions of capacity. We look at, are you using your existing operating capacity at a certain level, a high level, and that's the basis for justification of expansion. And so we're still proposing to apply that here. Instead of getting a CON, if you've got one OR and you're using it for 1,600 hours a year, that's punching your ticket to come in here and get an exemption review fairly quick and with a lot less information burden to provide to the commission, and we'll let you have that second operating room. I think we could think about and go back to the literature, and I think we probably want to not scare everybody, and I'm really talking about hospitals, by getting rid of that standard altogether. But I think we could probably write a standard that does give applicants the ability to actually say, well, here's why 1,600 doesn't work with the way I'm trying to do surgery at this facility, the type of surgery I'm doing, and the way I'm deploying my physicians and staff to, have throughput through my operating room. And we could give them the flexibility to present that alternative argument that says, well, actually, it's more like 1,400 hours or 1,300 hours for me that really works best with my particular model. We haven't had a lot of experience with people actually trying to use those types of alternative arguments with us. Over the years I've been here, maybe once or twice. And we've actually looked at that in particular with a couple of the folks who do fertility treatment. The way they kind of move from one stage to another sometimes makes sense in that direction. But I think we could look at that because like I said, I've seen some of that literature. I think we could probably craft a standard that allows people to make some alternative arguments based on the particular business model they have for doing outpatient surgery. I wanted to say too that in case it wasn't clear, this is all based on a statute that lets us do this, we think, the two operating room thing. It actually is logical to say, well, why wouldn't we then also let people go from 2 to 3 or 3 to 4? But again, that's one of those things that we'd have to change the statute to kind of do that. But if this works well, I think, that's one of the things we want to keep in mind when we come up with our list of statutory changes, which is coming, I can tell. We probably want to say, let's have simple ways for busy outpatient surgery centers to come back and expand OR capacity without the burden of a CON.
Terrific. In the interest of time, I'm going to suggest that we try to go through the last 4 or 5 pages in 5 or 10 minutes.
Okay. I guess I just wanted to say that, with the exemptions, we're talking about they just have one OR, so it's not that situation where maybe they have 2 ORs and they're using them differently. They just have the one. And then also, if it's 2 combining, we don't say they both have to be at some optimal capacity standard. It's just based off of the projection. So I just wanted to mention that. So this is just the need standard, which I think I've covered. So the location, this is something that we talked about with the work group. We wanted this to be something that people could actually take advantage of, and there was some concern that maybe they wouldn't have the option because the space next door is leased, or it's just not an option to buy the space or lease the space that's right immediately adjacent to this existing POS. And so, we talked about having some flexibility if it's a situation where you can't expand where you are or at an immediate adjacent location. And so we decided that a nearby site would be acceptable, and we define that as it's a site that you can reach by crossing no more than one public thoroughfare. And so we didn't talk about that specific definition of nearby as a way to give flexibility with the work group, but it did seem like they favored having some flexibility. We just didn't agree on this specifically. Efficiency is another project review standard. So an applicant needs to demonstrate how its project will result in more efficient and effective delivery of surgical services. We think that's consistent with the statute authorizing us to have this exemption process. And that's all of my slides, really. We're interested in your feedback. You've given us some today, and that's helpful. And we're going to look at this feedback that we get after the public comment period ends, which will be, I think, April 4th. And then we'll, of course, as usual, talk about the feedback that we've received, our analysis of those comments, and then bring back to you draft proposed regulations.
Given that there's been some friendly debate about how the market actually plays out in terms of levels of charity care, for example, relative cost, this kind of thing, is this information that staff could potentially pull together for the commission to have? I mean, it's almost like we were talking earlier about the certificate of need models, and coming up with a model that's consistent and saying, look, let's make sure we're all on the same page about what's happening in the market in Maryland, so that we don't end up with sort of a debate about some fundamental issues about are there populations that aren't being cared for in certain settings. Some saying yes, that's the case. Others saying no, that's not the case. It seems like some basic shared data about the Maryland market could at least get us past some of the kind of he said discussions.
We did include some information on the payer breakdown in the different settings in the draft that was posted for public comment in the issues and policy section. It's pretty basic. I think we just focused on like the current year. Oh, no, actually, we did have the trend, like over the past 5 years, how has it changed in terms of the bigger payer group? I don't think we specifically looked at charity care or self-pay as a breakout category, but I thought we'd focus on like Medicare, Medicaid, the private payers, and how that's different.
So I think what we can do, when we come back to you with further work on this based on the comments and discussion here with a proposed regulation for adoption, we'll also come back with a profile of statistical information that gives you some insights on the differences between hospital surgical care and non-hospital surgical care.
Super. Thank you very much.
Thanks.
Ben, just an overview of what's coming up on the agenda for next time.
So, yes, we deferred a number of issues that till next month, and they will be brought to you. We'll have an update on the healthcare quality reports website. It's already been updated, but I'll ask Teresa to fill in the commissioners on some of our other work, progress we've made with Leapfrog, some of the questions that folks have asked about delays in throughput in the emergency department, among issues that have been of interest to you all. The legislative wrap-up, the legislature will be complete. Their work will be complete. We do know there are a couple things that are active currently that may affect the commission. The most notable is this pilot to look at community integrated oncology program. As I mentioned earlier this week, it passed the House where it was strongly supported, but we don't know what the outcome will be in the Senate. We will also, David will be back before us to talk a bit about telehealth. I'll ask him to also integrate some of the recent findings on what savings we're seeing. We have some information locally, but there's been some useful reports done nationally that do talk about savings from particularly consumer-based telehealth programs. They'll also be highlighting some demos as well, programs that are about to go live. And lastly, we'll have a couple CONs, the expansion of the Kaiser Ambulatory Surgery Facility. They, as you recall, expanded one. They are coming forward with another application required under Maryland law that is primarily dedicated to their patients, but they are required to get a CON for that. And we also will review comments on the regulatory front on legitimate surgical services. And finally, our user fee assessment will be back before you. That was adopted in December as proposed. Final action. Thank you again for your diligence over the last several months with this and other activities. And we'll look forward to seeing you all in April.
If there's no other business, I'll entertain a motion to adjourn. Second, and all in favor? Aye. Meeting adjourned.